chairman and the organizing committee for being with them today. Also, would like to thank our sponsors for supporting such a distinguished event. Also, we'd like to thank our esteemed attendees for being here on a Friday afternoon. So this is the second session for today. The focus will be around graft versus host disease and transplant-related complications in gene therapy. We'll start first with Dr. Badr Al-Ahmari. Dr. Badr Al-Ahmari is the chairman of the Blood and Cancer Research Department at Abdullah International Medical Research Center. He's also a consultant adult stem cell transplant and cellular therapy at the Department of Oncology at King Abdulaziz Medical City, Ministry of National Guard Health Affairs in Riyadh. He will tell us today about graft versus host disease local experience. Dr. Badr, the mic is yours.
All right, Assalamu alaikum wa rahmatullah. Good afternoon, everyone. Thank you for the introduction, and I would like to thank the SSBMT Scientific Committee for the invitation to present our local experience in graft versus host disease. As we know, bone marrow transplant cure majority of patients with hematological malignancies and non-malignant hematological disorders. However, this is procedure is associated with a significant risk of transplant-related mortality. Graft versus host disease is a complication of bone marrow transplant that is associated with a significant portion of this transplant-related mortality. Acute GVHD, as we know, characterized by involvement of the skin, gut, and liver with inflammatory process that is mainly derived through the donor T cells. And chronic GVHD is another different complication from the acute GVHD with its own characteristics and pathobiology. We know this complication associated with a significant amount of transplant-related mortality. T-cell mediated injury is the main cause behind the acute GVHD pathobiology. However, chronic graft versus host disease differ in terms of pathobiology, in terms of the contributors of innate immune system and adaptive immune system. Recent registry-based data from ABMT megafile showed that there is actually a decrease in the incidence of graft versus host disease over the past decades, with the recent data showing that incidence of grade 2 to 4 acute GVHD is around 28%, and this has been also associated with a reduction in the non-relapse mortality as well. And I think this is highly contributed due to the improvement in the conditioning regimen and the novel prophylactic modality that's been pioneered. Chronic GVHD as well, in a recent data from CAPMTR showing that there is still an increased risk of developing this kind of complication. So, over the past years, there has been an increase in the transplant centers in Kingdom of Saudi Arabia, and this has been increased in the bed capacities, and this has led to increase the rate of bone marrow transplantation offered for patients within the kingdom. However, there aren't any a lot of data about the complications associated with this type of transplant, including data related to graft versus host disease. So our aim is to share with you the incidence of graft versus host disease within our institution, and also we shed a light of treatment pattern and clinical outcomes within our institution. We include patients aged above 14 and who underwent allogenic transplant. Of course, we exclude patients with the sickle cell disease because we've done a lot of them, but those patients, they receive actually non-myeloablative conditioning regimen composed of Cambath, TBI, and sirolimus, but this has been associated with very low risk of acute GVHD and chronic graft-versus-host disease, and this data has been published multiple times. The data has been collected between 2016 and April 2024. In April 2024, acute GVHD grading, we use the MAGIC criteria, and the NIH grading, we use the chronic GVHD organ scoring, and I did only descriptive analysis so far for our data. So we identified a total of 264 patients underwent allogenic stem cell transplant. 57 of them are male, with a median age of 27, ranging between 14 and 69, with most common diagnosis as acute leukemias, including AML and ALS, of course. The second most common indication for allogenic transplant was bone marrow failure. That includes sideroblastic anemia and inherited bone marrow disorders. Hemoglobinopathies is also included in this analysis because those are patients who were treated outside the CANVAS TBI platform. We use the Haplo platform, which consists of flow cyte TBI, Thyrotiba, and ATG and PTSI as well. So we included around 31 patients here with a different indication, including sickle cell disease and beta thalassemia. Lymphoid malignancies, including non-Hodgkin lymphoma and Hodgkin lymphoma, is around considered 9%. So most of the patients, they have a good comorbidity score, and they have also good performance status. Around 50% of our patients receive myeloablative conditioning, because you can see the high proportion of patients, they are actually non-leukemia. They are bone marrow failures or they are hemoglobinopathies. So majority of our patients, they receive, 50% of our patients receive myeloablative, but we have a good number of reduced intensity conditioning here, and as well as non-myeloablative. Of course, we have high rate of match-dated donor transplants, so around 66% of patients, they are actually match-dated donor, followed by haplotransplant, haploidentical, and followed by match related from the donor registry. The most common graft source was peripheral blood, around 83%. We've used the TBI in 43% of patients, and we've used an ATG in 44% of patients. Primarily the ATG, we use it in the MUD setting as well as in the hemoglobinopathy setting. BTSI is used in 22% of patients, and this is primarily for haplotransplant. We are slowly adapting the use of BTSI in match set and in MUD setting, but we're not there yet. The most common prophylaxis used, which is the CNI plus methotrexate, followed by CNI and MMF. And sirolimus MMF mainly for the hemoglobinopathies. So in total, we have an overall rate of grade 2 to 4 acute GVHD of 22%, divided between the most common is grade 2, 48% of the 58 patients identified, followed by grade 3 and grade 4, with a cumulative incidence of around 22%. The organ involvement, actually, as you can see here, the most common is lower gut and skin, followed by upper and liver. And the median time of onset was around 6 weeks. I did just a quick separation for the curve here. There was actually no difference between, although it looks like there is a higher rate in the myeloablative and reduced intensity, but still it's not statistically significant when compared to the non-myeloablative. Looking into the responses, so day 7 response to the first line systemic therapy, which is steroid, was around 65% overall response rate, 10% only CR, and 55% partial response. There were 31% progressive disease, and 33% of the patients actually went on to receive second line of acute GVHD. The most common second line was actually ruxolitinib, followed by ECP and anti-cytokine, which has etanercept and others, including ATG. So overall, the response rate at day 28 for all patients, all comer, including those who are refractory and all the only patient diagnosed with GVHD, the overall response rate at day 28 was 73%, with a 50% of them they are in CR, and 22 are in partial remission, 26 in progressive disease, and the best response was actually overall 84%, and finally 80% of patients achieve CR with different lines of therapy, and the median time to this response was actually 5 weeks. In terms of the outcome from the acute GVHD onset, we had around 47% cumulative incidence of death for patients after acute GVHD onset, and there were 9 deaths probably related to progressive acute GVHD. They actually died while on complete remission, and the relapse rate after acute GVHD was also another 9%. Okay, so now I will review the chronic GVHD data. So we have a rate of around 34% of chronic GVHD identified, 88 patients in total. 50% of them they are moderate, mild was 23%, and severe with 27%. Organ involvement, 30% they have only one organ involvement. 47% they have 2 to 3 organs, and 23% they have 4 or more organs. The most common organ involved was skin, followed by mouth, eyes, liver at 37%. Lungs, we identified like 20 patients with lung GVHD, and they constitute around 22% of our patients. Fascia and joint was the least at 10%. In terms of responses for chronic, systemic steroid was actually initiated in 88% of patients at one point. And the response at 1 month from the initiation of steroid, as you can see, 16% achieve CR, while 39% they achieve partial remission, and 43% they have form of progressive disease. Second line was initiated in 57% of patients. And ruxolitinib was the most common second line, followed by imatinib and ECB and then protinib. And ECB was actually used in third or beyond line, but it has been used here as a second line for patients. So responses in general for all comers from the onset of the GVHD, 60% they were able to achieve CR, and 23% they have stable disease, 6% they have PR, and 10% unfortunately they still have progressive disease. And with a median follow-up of 28 months for the whole cohort, the overall survival of patient was around 60%, and the care for graft-versus disease-free, relapse-free survival, this was actually acute graft-versus, it wasn't including the chronic, but as you can see here, it's reaching around 40% at 3 years. In the end, I would like really to thank our team and for the massive job that they have done for the improvement of our program and the establishment of clear policy and guidelines to treat chronic GVHD patients, improvement in data management and collection system for our GVHD patients, and special thank really to Ms. Inam Shahabuddin. She did a massive job really for the improvement of the program, as well as to collect this data for me. Ms. Shahabuddin, actually, we are missing her really a lot. She's leading the program, and we wish her all the success in her future career. Thank you very much. And
thank you very much. You can stand with us. Maybe we'll get a couple of questions before we go. Any questions from the audience? I can start with the first one.
Sure.
This is actually an enormous work. Database
Sure, absolutely. Thank you very much for the question and for the compliment about the data set and for the question actually. That's true. I agree. I mean, there are multiple data showing that baseline characteristic affect actually the incidence of the GVHD and also the outcome of the GVHD. We have a good data here, but I didn't have the time really to do some statistical analysis to get this information out. But actually, we are working to finalize this, and we're planning to submit the abstract in the future EBMT conference. And so we're working on that, and I agree with you. Yeah, we should have some data about linking the patient baseline characteristics with the incidence and the outcome of the GVHD.
Any questions from the audience?
Also, I agree with Dr. Mohammed. It's good to have data from our community, our patients, just to see if they are different from others. So I think the best way is to collaborate between the centers to have more number of patients, to have more precise data. And the other point, I don't know if I missed this, but I understand the number is 264. But you have around 2/3 of your donors were match set and 1/3 were others. And you have like homogeneous GVHD prophylaxis approaches. So do you have any subgroup analysis based on the type of donor, type of GVHD prophylaxis?
Yeah, correct. Yeah, I mean, I haven't done any of these data. It's very essential, very important, but we are working on that to. Although the number is small in general, but we can still have, because I did only one for the conditioning regimen and it didn't really affect the outcome. But still, I mean, we can still do that. Yeah, it's important. Yeah, I agree with you because of as you said, the data are so heterogeneous and there might be a factor that contributes to the outcome that we see.
Any other question? Okay, so if no questions, thank you, Dr. Walid.
Thank you very much.
Okay, so the next presentation is video recorded by Professor Mohammed Mufti. Professor Mohammed Mufti is a professor of hematology and head of hematology and cellular therapy department at the Saint Antonia Hospital in Paris. So please for.
First of all, I would like to start by thanking and congratulating the organizers, especially Dr. Ahmed Al-Askar and the whole SSBMT leadership for this lovely event. This event has become a well-established tradition, and I think you can all be proud of this achievement more than 10 years after its launch. And a big thank you for all the colleagues in the Kingdom and in the Gulf region in general for everything you're doing to advance and improve patient outcome in the region and beyond. So as part of this post-Congress activity, I have been asked to give you a summary about the management of GVHD from prophylaxis to therapy. And one may wonder whether there is anything new in the field of GVHD. And I'll try to convince you that there is a lot of advances. I'll be very straightforward, and I think everybody is convinced that now the use of high-dose post-cyclophosphamide that was introduced by Leo Luznik, Paul O'Donnell, Ephraim Fuchs, and many others from Hopkins has been a sort of a seminal advance in this field. And I'm sure most of you are familiar with this slide about the original design of this so-called post-side platform in the haploidentical transplant field. Of course, it has been modified since, because we're not using anymore the small dose of cyclophosphamide as it has been established in mice, and of course now we use 2 days of post-side. And the initial results are shown here. Clearly, you have a significant control and decrease in the incidence of severe acute GVHD, but also in the incidence of extensive chronic GVHD. But this was in the bone marrow setting, bone marrow as a stem cell transplant source. With this background, with these data, I think the community started using widely post-side for GVHD prophylaxis in the haploidentical setting. And then automatically, the key question one can ask, why can't I use post-side for GVHD prophylaxis in the mismatch setting? And this is exactly what has been done in this work from the Acute Leukemia Working Party of the EBMT, published now more than 4 years ago, actually, showing that using post-side in the HLA mismatch unrelated donor transplant is able to reduce, to decrease significantly the incidence of severe acute GVHD compared, for instance, with ATG, which is historically the standard of care. But not only you have a decreased incidence of severe acute GVHD, but this will translate into a better survival. And this was established in the setting of acute myeloid leukemia, which represent today the key indication for allo transplant. So we know today that in the mismatch setting, also post-side is widely used. But of course, outside the haplo and the mismatch setting, is there a role for post-side? And in the matched unrelated setting, for instance, but also in the matched sibling donors, we know that the use of rabbit ATG is very well established. And we do have prospective randomized trials, mainly in the unrelated setting, only one trial in the matched sibling setting, clearly establishing the value of ATG for GVHD prophylaxis in the myeloablative setting. And this is why in European countries, ATG is the backbone for GVHD prophylaxis in the matched unrelated donor and in myeloablative conditioning transplantation, but also in reduced intensity conditioning transplantation. We have performed randomized a trial in the reduced intensity conditioning setting using standard approved in Europe conditioning fludarabine, IV busulfan, ATG thymoglobulin with cyclosporin and MMF versus fludarabine, IV busulfan and post-side plus cyclosporin MMF. And this was in the matched sibling donor and then a fully matched, unrelated donor. And this study received the EBMT 2021 Van Bacon Award and was recently accepted for publication with a relatively long follow-up. And the bottom line is here, the results. The cumulative incidence of relapse is similar between ATG and post-Cy. Cumulative incidence of non-relapse mortality is similar. And at the end of the day, leukemia-free survival is similar. So it looks like, although this study, the primary endpoint was about showing that maybe post-Cy is better, actually it doesn't look like to be better. So post-Cy is here to stay, it is well established. However, probably if you have already an important experience with post-Cy, you know that it has some glitches. It's not as easy as it appears. And already 4 years ago, and since we started using post-Cy, and actually our first patient who received post-Cy, believe it or not, actually are from a protocol which started in 2006. So that was quite a long time before post-Cy became routine and standard of care. And we immediately could notice that high-dose post-Cy, as developed by the Hopkins group, namely 50 milligram per kilo per day for 2 days, can lead to some important early cardiac toxicity. And this will have an impact on the overall survival. And this is important because the population that we transplant more and more is an elderly population with comorbidities. And we know very well, and I think this is very relevant to you in the kingdom, that cardiovascular comorbidities are a matter of concern. So with this description, with this in mind, how can we do better? Actually, we started immediately by reducing by 20% the dose of post-Cy. And that was a single center analysis that we published in 2023, in April 2023. And we could show that actually you can reduce by 20% the post-Cy dosage in the haploidentical PBSC setting. And of course, these were elderly patients where we thought they had a risk of cardiac toxicity. And we were very pleased to see that there is no difference when it comes to acute or chronic GVHD, any grade. So very good findings, single center of course, but most importantly, we could see that we have less BK virus related hemorrhagic cystitis. And most of you are well familiar that that could be a matter of concern in those patients when you use high-dose post-Cy. And actually, we have even a quicker platelets and neutrophil recovery. So really very good news. And I was very pleased to see a few months ago that our Japanese colleagues were able to reproduce our findings. And what we are currently doing to further optimizing the post-Cy platform in the PBSC setting. And why we're focusing on the PBSC setting? Well, because this is the major source of stem cells, but also we know that in contrast to the original experience with bone marrow published by Hopkins, when you use PBSC, actually, the risk of acute and chronic GVHD is higher. And one idea is actually, in order to improve the safety, so reducing the dose of post-Cy, but also improve the efficacy, adding a small dose of ATG. And we started doing this almost 10 years ago, 2013 actually. And we published 2 years ago our original experience looking into the 100 milligram per kilo versus 70 milligram per kilo of post-side plus ATG, of course. And this has been published, it's open access, you can see the data. But again, you can reduce the post-side dosage by 30%. You can add a small dose of ATG, thymoglobulin 2.5 milligram per kilo, and actually you can gain in terms of GRFS. We know that this is an important endpoint for us in the field. And now what we're currently doing, we're actually doing a phase 3 randomized trial, a national trial in France, and hopefully in a few years we'll get these results. So you can see the prophylaxis setting is moving very nicely, but things are also moving in the management, for instance, of steroid refractory acute GVHD. I won't spend a lot of time explaining. Ruxolitinib has been a major advance, established thanks to this phase 3 randomized trial, the REACH2 trial, and ruxolitinib has become a standard of care. But now we are faced more and more with patients who are ruxolitinib refractory and steroid refractory. And with a group of colleagues, we have set the frame to define these patients who are ruxo refractory for their acute GVHD. And this is where we need novel options. And this is where fecal microbiota transplantation, the transfer of microbiota, and we're currently developing this product, transforming the fecal material into true drugs, clinically validated, MAT13, which is an enema, MAT33, which is the oral for the capsules. And at the last SSBMT meeting, my colleague, Professor Malar, presented the compassionate use, the European compassionate use of MAT13, the expanded access program. And of course, these are ruxolitinib and steroid refractory. And again, we have a very nice overall response. And the majority of responses are CR and VGPR. And actually, the outcome of those patients who achieve CR, VGPR, or PR is going to be improved. We have actually 58% overall survival at 1 year and a half. And currently, we are running a registration trial in this population, and hopefully we'll get these results in a few months. GVHD management is also improving, not only in prophylaxis, not only in the acute setting, but also in the chronic GVHD setting. And we have some very good news when it comes to steroid refractory chronic GVHD. Ibrutinib, I think you're well aware of it, although I think in Europe, in the Middle East, it's not very popular. Ruxolitinib is clearly now a standard of care thanks to the REACH3 trial. But also now we have a ROC inhibitor, namely belumosudil, which is making a true difference in the life of many patients, and it was approved by FDA. So here you can see the results of the REACH3 trial, ruxolitinib for steroid refractory chronic GVHD, a clear and significant difference compared to the best available therapy. This is why ruxo now is widely used. But we have now this newcomer belumosudil in the ROCKSTAR study, heavily pretreated chronic GVHD, including patients who received actually and failed ruxolitinib, and you have an overall response rate of 76%. Very quick response in less than 2 months, and this is a long-lasting response. But the field of steroid refractory chronic GVHD will continue to evolve. I'm sure you will see very soon some data with a novel agent, a monoclonal antibody, a monoclonal antibody anti-CSF1 receptor, namely axatilimab. So watch out for axatilimab. So in summary, I think we can reasonably conclude that POSI is now well established for GVHD prophylaxis, including outside the haplo setting. However, we still need to optimize the POSI platform by dose reduction, maybe combining POSI and ATG. In the steroid refractory acute GVHD, we have ruxolitinib, very well established, but unfortunately, we have patients who will not respond to Ruxo, who will be resistant to Ruxo, and this is why you need other options, and modulation of the microbiota is proving to be successful, and hopefully we'll get some good news in the next few months. In steroid refractory chronic GVHD, again, the field is moving very nicely. We have ruxolitinib, we have perimosudil, and maybe another agent very soon. So you can see the field is really moving nicely, and this is really good news for the field, but also for all the patient, because we should not forget that allotransplant remains a potentially curative option for many patients who don't have other options, especially those patients with mild malignancies. So with this, I'd like to thank you all for your attention. I would like to wish you a successful meeting, and inshallah we will be able to meet at some point in person. So thank you very much, and I wish you a lovely meeting. Thank you.
Thank you very much for your introduction, and really I would love to congratulate SSBMT for the 10th anniversary, and as well as switching gears. My talk will be about sickle cell transplants and our local National Guard Riyadh experience, including the haploidentical transplantation. It will be switch gears from GVHD to sickle cell transplant and some pediatric data, but also we'll go through the adult data, some of the adult data that Dr. Mohsen Zahrani and Dr. Badr and the team in the adult that shared with us. It is also a continuation in the same theme that the field of stem cell transplantation continues to evolve very quickly. Disclosures about the relation to the talk is some research support for Hopkins 2 trial for voxelotor and from Vertex as well. So we'll go through some introduction, and then we'll go through the pediatric classical approach of match-related donor transplantation, the conventional myeloablative regimens, and then we'll go through the reduced intensity and finish with alternative donor transplantation. So as you know, sickle cell disease is the most common inherited blood disorder in the country that affect at least between 60 to 90,000 patients, even more than that in the recent MOH data. And if you just do the calculation, there are multiple studies and estimation, around 20% at least of sicklers are candidate for, they are severe enough for leaning toward curative therapy such as transplantation or gene therapy. And if you see globally, the interest in transplant and sickle cell and treatment in general have increased dramatically. I mean, the first transplant in 1984 for a sickler with AML, and now you see how the numbers are increasing in different countries around the world. But we have to put one thing in classical treatment for the selection of those patients. It is very well established, at least in the last 20 to 30 years, that the younger they are, if you use the classical conventional myeloablative therapy, the better the outcome. And studies range from the age of 13 to age of 15, where if you transplant them earlier than that, you will have a better outcome. And the usual outcome that the registries have published, whether in the EBMT or the CIBMT, are talking about more than 95% or more than 94% of them are survivals for more than 1,000 patients. But that's not true for the other kind of alternative transplantation. If you go and looking at those curves in this earlier study, of course, at that time, matched unrelated donor and haploidentical transplantation had a lower, and you could see that the gap of around 30% lower is significant, whether in overall survival or event-free survival. And that put in a stress on who to transplant. And you have two schools in that, and a school that says transplant them early before they get more end organ damage, and everyone with matched sibling donor go and transplant them. But the other, if you look at the number and the population and many other different sources and regulatory areas, priorities go to severe disease. And this is one of the NIH approach had published that long time ago with the some of the indications, as well as the American Society of Hematology guidelines in 2021. But you could see the long list of matched sibling donor, you could go there, but you start to go for alternative and unrelated donor once you have very severe disease, talking about recurrent acute syndrome, recurring ICU admissions, and moya disease, and recurrent or having a stroke, putting those patients on regular transfusions program. I took this from Dr. Mahsen, this slide, courtesy go to him, but of course to the publication of Prof. Gluckman about why the outcome in pediatric and adults, and of course organ damage, multiple transfusions, iron overload, and impaired immunity and are risk factors. So if the overall survival with the myeloablative classically is 95 in pediatrics, in adults it used to be around 81%, maybe higher right now, as we'll come to. So when we dissect that to conditional regimen in a pediatric age group, the EBMT has published also in the British Journal what is the common and BMT Pediatric Working Party. People have changed from BUSI ATG toward other regimens, and in the last publication, you would see like 60% of their population are using in the registry treosulfan, fludarabine, thiotepa. Now, treosulfan is not approved in all the countries, but this is one of the things that people have been using. In addition to the use of serotherapy. Now, in our hospital, with a homogeneous society with a high rate of finding match-related donor, since 2010, a group of multiple generations have done a lot of work in sickle cell, acknowledging previous Prof. Abdurrahman al-Sultan and the whole group in the society. Around 450 patients were allogenic transplant, but you see hemoglobinopathy accounts around 42% or so, and 30% are sickle cell. And the initial 40 patients, when a trial was led by Dr. Prof. Abdurrahman about using REC, did not show at that time in pediatric, similar to what we were hearing from the adult, that the outcome is so great in sickle cell. We've used regimens that was as under clinical trial with ATG, melphalan, and fludarabine, and also some other patients were using Campath, flu, and melphalan. And as you see here, the event-free survival were much lower in the RIC group, and a lot of them had graft failure. They're all survivals, but they all had graft failure. So if you look at the cake in our hospital or how much was done, the majority are myeloablative with TBF regimen, so thiotepa, busulfan, fludarabine, and we have presented that in the last SSBMT using this regimen, using thiotepa and targeted busulfan dosing with calcineurin inhibitor and methotrexate as GVHD prophylaxis. And the main indication were recurrent painful crisis in 32%, and 29% of those had a stroke. You also could see here out of those, interestingly, the ages from 2 to 14, but from out of those, 80% had matched sibling, but some of them, like 20%, were matched related, which means one of the parents or the cousins, which we not often, we could see it in our population sometimes in IRIX. The busulfan level was ranging accumulative around between 50 or 60 to 70 in general, and as expected, the neutrophil engraftment and platelet were between the median 20 and 29, with acceptable full donor chimerism and a mixed donor with no graft failure. And the main complications were around mild VOD in 15% and occasional press, although they are managed as many other patients with sickle cell with Keppra prophylaxis and keeping the platelets high and blood pressure control. We also found here as well that they have some infections, but the overall survival of those similar to international, I mean, it's around 99%, but we had one mortality at day 88 from IPS or idiopathic pneumonia syndrome, but we did not have graft failure. But we have also some elements of GVHD. If you combining, they're around 6%, some of them had both acute and chronic, but they're all mild and none had severe. On the other end, our colleagues in the adult have published initially collaboration with the NIH group and later on our own data here, starting from 100 patients to almost now 300 patients, using the alemtuzumab TBI regimen with sirolimus as an immunosuppressant. But before that, those patients get hydroxyurea 3 to 40 milligram per kg and for at least 60 days with hypertransfusion. And that made an excellent outcome. And as you see here on the side, compared to the outcome published by earlier in 2017, it's with a good follow-up, it's in a higher range as an overall survival around 90 plus %. So then came the question here, who to do and what is the advantage of each? And maybe in pediatric it's a little bit different than the adults based on their immune system. The alternative donor in terms of MUD, haploidentical or cord has been raised. Now I'll not spend time about cord blood transplantation, but it's still one of the, if you have a family matched cord blood in a high-risk patient, you could consider it in a sickle cell patient. We've done that only in one patient and it did well, but this is something hopefully in the future with cord blood expansion. But the problem with match unrelated donor in the sickle cell, that it has a high rate of GVHD, more than 30% if you see in this publication by Shinawi et al. And we elected in our society just to do only minimal, some match unrelated donor, but only limited to local registries, knowing the consanguinity and the relationship and we just added, as Prof. Marty, the classic ATG prior to infusion for 3 doses, and those patients did well. Now, moving to haplotransplant, it's a long story, but the Hopkins group looking at the PTCY, because this is the most popular, accessible way in our country and multiple countries around the world, and it's cheaper. They started initially with an approach using the flu cyclo-ATG and a TBI of 200 only, but that led to a lot of rejections, and about 40% of those patients rejected. Later on, multiple consortium around the world have been focused on what to do and modify this regimen. So a group have increased and modified the TBI to 400, and they decreased the rate of graft rejection down lower to around 10%. On the other hand, the group in London added thiotep around 10 milligram earlier per kg and modified in the preconditioning with time, in addition to changing in the GVHD prophylaxis area. And it was also promising that led later on to a collaborative group between multiple countries, North America, Europe, as well as the Vanderbilt group with Dr. Aditola Kasim and the group, and the St. Mary groups, and in Saudi Arabia between the National Guard and King Faisal Hospital and the adult group. The pediatric have also got involved in that lately, and we are using this regimen, adding thiotepa, but on top of that, doing hydroxyurea very rigidly for 60 days and hypertransfusion to keep the hemoglobin high and keep the hemoglobin S less than 30%. So the reason I'm saying this, because the publication recently, it was very interesting by Aditola and the group in that consortium. And you look here that the outcome and the overall survival is excellent, around 5% mortality with this haploidentical approach, and around 10 or 11% had graft rejection. But when you dissect that for those 70 patients into who are the patients who rejected, they end up to be, all of them are pediatric patients, less than 18. So if you look at the slide on the left, the pediatric cohort, and you do the sub-analysis, around 70% the event-free survival. So it means 30% they rejected. Now they all had autologous recovery. On the other hand, in the adult group, they were like the rate of mortality was around like 7%. Because of infectious complications. What's this other striking thing, the GVHD rate was 10%. So another subgroup, so after this publication and looking at the data, we tried to segregate, and we had the pediatric group in the National Guard group, and St. Mary in London, and the Vanderbilt group have collected the data looking at the hydroxyurea and hypertransfusion for those indications for haplotransplant like stroke and severe cerebrovascular and severe vaso-occlusive crisis. We had 26 patients, and the age ranged from 2 to 16 years, with a median infused TNC of 4 and the median infused CD34 of 4.7. Remember, those are all bone marrow, they're not peripheral blood. The median neutrophil engraft were around 21 days and a platelet of 41 days, and the outcome was better than expected compared to the whole group. So a good full donor chimerism in a majority of patients, and this is what we got. Overall survival 94% and a disease-free survival around 89%. Now there was one death late because of pneumococcal sepsis, was done in otherwise off immunosuppression patients who was not compliant, and there was no cases of VOD. But the other problematic part was the GVHD. So if you calculate grade 3 and above, allow for acute around 11%, and if you look at moderate to severe, around 4 patients, so around 15%. So this is still could be something that we could improve in. The strategies, as you know, for haplotransplant in Europe is also different. You could also do the ex vivo depletion with alpha beta depletion. And the publication, at least in the pediatric age group, of 20 patients with haplo who received myeloablative TFT, so a treosulfan based, is also promising with 90% overall survival, but also still a GVHD around 20%. So based on that, the conclusions, we are seeing that the choices of preparative regimen and conditioning regimen is still evolving and getting better. The use of alternative donor BMT is still something that also evolving, especially the haploidentical setting. For the match unrelated with the newer GVHD prophylaxis, I was speaking to my mentor, Dr. Abdullah, and we were talking about other agents like abatacept and others, and how to incorporate that in the match unrelated and mismatch unrelated donors. And of course, gene therapy is one of the things that also would be on the table to discuss. So with that, I would like to thank you for listening, and sorry if I exceeded time a little bit. Of course, thanks to all the patients who contributed to this. Of course, the huge team between the medical, the clinical, the laboratory, stem cell lab, and the apheresis teams, and the support from everybody. And again, thank you for SSBMT.
Thank you, Dr. Mohammed. Actually, timing is perfect. Do we have questions from the audience? Dr. Mohammed?
Thank you, Mohammed, for elegant presentation. I have a question for patients who that used reduced toxicity conditioning with fludarabine, thiazepan, triosulfan, and busulfan. Have you followed on the chimerism of these patients with time, and did you observe any?
Yes, so the majority, so in regards to immunosuppression, we keep the immunosuppression between 6 months to 1 year for the tacrolimus, the FK. We can, the outcome is great, around 80% and above full donor chimerism for a long term. We have around 15 to 20% who have mixed donor chimerism. We have never seen any rejection in the whole 100 days. Now, some of them have a shorter follow-up than the others. We've been using this regimen since 2015. We have only one patient who had the lowest chimerism we have is around 40%. It was only one patient, and is still doing fine without crisis, without anything, and the hemoglobin S has been always stable, despite removing the immunosuppression and everything. The question about GVHD and how we can lower this, I mean, historically ATG has been used in sickle cell to alleviate GVHD. We have seen around 8 to 10 patients now with a longer follow-up with GVHD, but they are mild. But it is also something that we keep in mind in a matched sibling bone marrow donors. We could not compare that with our colleagues in the adult using peripheral blood and the rate that was discussed today. But again, even the adult data is very promising with the REC. With the GVHD part, with using CAMPAT, they're not having that. But the mixed donor chimerism is something that they have seen. But if that's the aim and it's stable, then maybe this is the way to go in the aim of the transplant. Despite some on and off reports that we are hearing, but we're not seeing about the risk of clonality, etc., that I am not aware our colleague have faced any patients of the 300 plus patients that they have done in the adult group.
Any other question? So this actually looks very. This actually looks very safe. In fact, I will quote what you have said at the beginning, whether or not we were showing the NIH criteria and what are the indications. Do you think with lots of excellent work you guys are doing, the timing for allotransplant may actually move sooner than when these complications are about to happen?
Sure, and this is the argument all the time that we are stuck with it, because really coping with the number of patients, I mean, if we put things on the table and reality, yes, it's great, it's ideal to do them as early as we could. But let's remember one part that I did not discuss here, the issue of myeloablative affecting the fertility of those patients, which is something also that is very important in our society. And taking someone who is not so severe at that age, and with the excellent outcome of our colleagues in the REC now with the adults, I think we have to relook at all these things. Of course, fertility preservation is something that we have to move on and do it in the future. That also could, help in the decisions of this. It's always the question about, this one patient's mortality that you have, or the couple of GVHD, and if they did not have that severe disease, it is just a nightmare sometimes for the medical team. Yeah.
Thank you very much. My name is Dr. Shad. So I worked before the King Faisal Specialist Hospital and the later hospital as a consultant. Doctor, do you think the red cell albuminization for the sickle cell disease, we need the desensitization before this haplo or something? Or does it affect the outcome of the transplant, GVHD, and rejection? So this is my question.
Thank you very much for this question, and it's very tricky and difficult. Now, in our population, we've done only 4 patients with aluminization and the 100 patients that I described. But there are patients who are aluminized, and there are certain preparations, certainly in the literature and in the data, and very logic that the rejection rate will be higher. Now, there are multiple ways to deal with that, and different regimen, people do different things. I find it more challenging with the thalassemia patients, so we have to do more work on them. Sometimes we do rituximab and steroids and others. In sickle, it depends, and also we do cross-matching between the donor and the patient, and sometimes we need to do RBC depletion as well, even if it's different, so we have to do cross-matching. We have tried in one patient an extra plasmapheresis prior to transplant. But in the setting of thalassemia, not in a sickle cell patient. I'm sure our adult colleague, but serotherapy, Campath or ATG, I think these are the things also you would think in mind. Maybe in those patients it's better to put it on board for those who do not use Buthu. I'm just thinking, but in our patients, this is what we have done. But also I'm sure our colleagues, maybe Dr. Abdullah, Dr. Badr and the rest, if they have any comments on that.
Any other question or comment? Thank you, Dr. Mohammed.
So we'll move to the next session, which will be a satellite symposium sponsored by Vertex. We have 2 talks in this session. The first speaker is Dr. Abdullah Jeffrey. Dr. Abdullah is a consultant pediatric hematology, oncology, stem cell transplantation. He's the director of hemoglobinopathies program at the Department of Pediatric Hemato-Oncology, King Faisal Specialist Hospital and Research Center. Dr. Abdullah is an associate professor at College of Medicine at Al Faisal University. Dr. Abdullah is going to present for us here about the gene therapy as a new era for hemoglobinopathies. Dr. Abdullah, the microphone is yours.
Assalamu alaikum. First, I'd like to thank the Society and Vertex for giving me a chance to share with you some of the experience in gene therapy and the update on the recent gene therapy updates that was presented in EHA. These are my disclosures. Let me give you an idea about the magnitude of the problem of sickle cell and thalassemia around the world. And as you can see, the distribution geographically extends from the Middle East, the Southern Europe and North Africa, and extends to parts of Asia and Far East. This is true for thalassemia. And the disease is endemic in Africa. And again, all of these diseases are spread all over the world now.
Now, for thalassemia, there are 60,000 births per year and around 300 beta globin mutation. That tells you the complexity of this disease, especially for preventing disease and couples who are interested in having a healthy child. The magnitude of sickle cell is an even larger, with 300,000 births per year. In our country, as Dr. Mohammed mentioned, we have it's estimated around 90,000. This is the structure of the hemoglobin. As you can see, the normal hemoglobin is formed of 2 alpha and 2 beta. And as you can see, they are symmetrically held to give them its functional aspect. Sickle cell disease and thalassemia are beta globin abnormality, when sickle cell is a functional or a qualitative problem of the hemoglobin. Under certain stresses it becomes abnormal and causing all the pathology. As I mentioned, there's one amino acid substitution that under certain stresses the hemoglobin S becomes rigid when it forms polymers and leads to a rigid cell that clogs and obstructs the tiny vessels. Not only that, this is the initiation, but the red blood cells themselves, they are hemolyzed and they release the heme and the hemoglobin that consumes the nitric oxide, which is important for the integrity and stability of the endothelium, that leads to the injury of endothelium and the expression of the adhesion molecules that attracts different sort of cells that really increases the problem and leads to further inflammation that is released from the white blood cells, attracting white blood cells, platelets, and then aggravate the pathology and the vasculopathy. Now, the sickle cell disease is almost every organ in the body is affected, and it can present as clinical manifestation, but that's the only the tip of the iceberg, because other organs are involved without manifesting symptoms, in particular the brain, the kidneys, the lungs. So it leads to different pathology, and those diseases manifest later in life with life-threatening complications. As you can see, all of the organs are involved here, and some of them are life-threatening. They can manifest either in acute or in chronic basis. Beta thalassemia, you have a problem of making the beta chains, and these patients are unable to produce enough red blood cells. Therefore, they rely on blood transfusion since early infancy. As I mentioned to you, the integrity of hemoglobin is important to keep the structure functioning. But if you lose the beta globins, what will happen is that the alpha heme aggregates will precipitate in the cells and leads to red blood cell destruction and the bone marrow excessive production or an ineffective erythropoiesis that will lead to severe anemia, expansion of the medullary cavity, and the causing skeletal deformity of the skull, the face, and different bones in the body. In addition, they lead to extramedullary hematopoiesis and further on. As you can see in this picture, this child is affected in different ways due to the disease itself and due to the treatment, which is blood transfusion with iron overload. As you can see, different organs are affected. You know, the skull, the face. You can appreciate the hepatosplenomegaly, the osteoporosis. These patients have stunted growth, abnormal endocrine organs. The iron overload becomes a problem if not introduced iron chelation early in life. It will lead to deposition in very important organs like the heart, liver, and endocrine system that will lead to endocrine dysfunction, hepatic cirrhosis, and cardiac dysfunction or arrhythmias, and can be fatal. So the current therapeutic options, there are disease-modifying therapies, sickle cell disease. Of course, transfusion can be given when needed. Hydroxyurea is a very important medication, and that should be introduced early in infancy to prevent and improve the quality of life of these patients. L-glutamine and voxelotor and other FDA-approved medication that were introduced. For thalassemia, these patients rely on transfusion for survival. Therefore, early introduction of blood transfusion in addition to iron chelation is important if these patients are to have almost normal life. And we have examples of successful people who are leading normal life by taking regular transfusion and iron chelation. Luspatercept is another medication that is approved to decrease the number of transfusion. Mitapivat is another one to reduce hemolysis. It's going to be soon a regular medication for the disease and other hemolytic diseases. The standard therapeutic curative option is the hematopoietic stem cell transplantation that Dr. Mohammed have already touched base with you, especially for hemoglobinopathies. Nowadays, we have the introduction of gene therapy that can be offered to some patients, whether it's through the gene addition or through gene editing, and I will explain that to you. So first, stem cell transplantation, best results are when this procedure is done early in life. That means usually children, preschool ages is ideal. However, we have limited number of donors. Yes, in Saudi Arabia, we have much higher chances of having an identical sibling donor, but still there are a significant number, at least 40% do not have donors. And the options are either unrelated donor or haplo-identical. As Dr. Isa mentioned, the unrelated donor are associated with severe complication, chances of GVHD, chances of rejections and failure are high, beside the complication of graft versus host disease. Haplo-identical transplant is another alternative transplant, but again, this is associated with multiple severe complications like graft rejection, reactivation of viral infection like BK virus, adenovirus, CMV, that becomes chronic and difficult to manage. Graft versus host disease is really a major challenge in this category of patients. And more seriously is the immune dysfunction that stays with the patient for a long time, manifesting as either GVHD, autoimmune phenomena, or repeated infection, and even lymphoproliferative disorders can happen from this sort of transplant. Thus, the chemotherapeutic toxic effect is well known, especially if you're using myeloablative conditioning, and the fact that the transplant is allogeneic, you have all sorts of complications related to the graft itself. Now, as Dr. Isa mentioned, the ASH recommendation is that any symptomatic patient with sickle cell can be transplanted and prevent further complication later in life. Because sickle cell disease is a progressive disease. As these patients grow, they develop organ dysfunction and they're likely to have shorter lifespan. And now in Saudi Arabia, it's probably more than 10,000 patients are in need for transplant if we are going to transplant them. However, we have limited capacity to accommodate these patients. Therefore, we set a criteria for severe types of patients, those who have multiple veno-occlusive diseases, recurrent acute syndrome, any sort of cerebral vasculopathy. Of course, stroke is one of them, but any vasculopathy will be an indication for transplant. Those who suffer any neurological deficit, of course. And patients with pulmonary hypertension, patients who develop sickle nephropathy are legitimate candidates for transplant. However, patients with chronic problems like allosensitization, recurrent priapism, and osteonecrosis, and the list is long, they can be included in the list to transplant. We come to the gene therapy. we know that gene therapy, if you talk about gene addition, that is to add a desired gene to the genome. This is done through lentivirus vector, that is a vehicle to deliver the genetic material down to the DNA and get the functional beta-like globin gene to function. And gene editing is through using the CRISPR-Cas technology, and basically this is like a molecular scissor where you can act and manipulate the gene that you want to do, and in practical purposes to disturb the BCL11A gene that's used in both either gene addition or editing to reverse the fetal hemoglobin repression. Alternatively, you can even correct the beta globin mutation. So if we are to select an ideal gene therapy, what are the requirements? You need high level of expression, especially if you have severe phenotype, for example, like severe beta thalassemia. You have to have controlled erythroid specific gene expression. You need to have stable long production gene product, and to avoid insertional mutagenesis or what is called off-target effects, because they can have deleterious effect. The two products that are available and FDA approved is the XSL, which is a gene editing that is approved to be used in patients with severe vaso-occlusive crisis in sickle cell or transfusion-dependent beta thalassemia for patients older than 12 years old. In fact, it is the first FDA-approved therapy that is utilized for clinical basis. The other one is the Beticel, which is a gene addition that is also FDA approved, and again it was approved for patients with vaso-occlusive crises and patients with transfusional beta thalassemia older than 12 years. So what is gene addition? Gene addition basically is to utilize the lentivirus as a vehicle when you introduce the desired modified gene into that vehicle, and this virus will be internalized in the cells, packaged in the endosome, and the gene or the genetic material will be released once it incorporates into the genome. Mind you, the lentivirus is an RNA virus that is through the reverse transcriptase transferred to DNA that incorporates itself into the genome DNA. The idea is that if we take, for example, the BAT87Q, which is a modified beta globin, it will be inserted in a certain place in the DNA or in the gene, and with that it becomes functional, and you can trace it after engraftment, and you can see the contribution of this gene. Now it has anti-sickling effect. The amino acid change in here makes it anti-sickling, and therefore it's effective in sickle cell as well. How this procedure takes place: first, the patient will be mobilized by plexiform. The stem cells will be collected, and then these stem cells will be transduced with the desired viruses or vehicle, or what we call vector copy, that will be internalized, and then it will be tested, stored, cryopreserved, and sent to the patient. The patient, meanwhile, will be conditioned with busulfan and then injected with the product. After engraftment, the drug product or the specific gene that is desired will be traced, and you will know how much it contributes to the hemoglobin. This is a study that was done by Locatelli and was released on 22 patients on non-transfusional beta thalassemia and 2 patients who have severe transfusion dependent. As you can see, the contribution of the gene has been significant as if the total hemoglobin was 12.6, and the contribution of the inserted modified gene is 10.6. And as you can see on follow-up, this blue bar indicates that they are transfusion-free. 2 patients, unfortunately, did not do well, and these happen to be the severe transfusion-dependent type. In sickle cell, similarly, you can see that the last 2 years they have multiple vaso-occlusive crises after the infusion of the drug product. None of them developed vaso-occlusive crisis on follow-up. The contribution of this gene is around 45% in all the group, and again, this happened to be protective to these patients. Now we come to the gene editing. The idea of gene editing to allow very precise changes in the DNA. The genetic material can be either disrupted, deleted, corrected, or inserted at precise location, a specific location in the genome. There are several clinical trials utilizing the gene editing. I'm not going to go through them, but thanks to these 2 scientists, Dr. Carpentier and Dr. Dudna, they won the Nobel Prize in 2020 in chemistry for their discovery, the CRISPR-Cas9. Interestingly, their observation on how the bacteria defends itself against viruses was through this mechanism, and they learned that and applied it on humans and clinical trials. The idea of CRISPR-Cas in clinical practice is that CRISPR-Cas consists of Cas enzyme and single guided RNA. Now, the Cas and single guided RNA form a complex and function as a unit to edit the DNA only when it reaches specific location, because they have specific codons that comes to that specific point. That makes the precision. During the repair of the edited DNA, a change in the target DNA sequence is introduced. And the change in the target DNA sequence inactivates the gene or alters its function. Now, there are 2 ways of repair here, what we call directed repair, when you have the mutated gene altered and made dysfunctional, and then an introduction of a DNA template that fixes the mutation. With that, they fix the abnormality. The non-directed repair method is that if we take, for example, sickle cell disease, as you can see the hemoglobin clumping, what you do is to disrupt the BCL11A gene and leave the gene to heal spontaneously and naturally. With that, you arrest or you repress the BCL11 and enhance the production of gamma globulin. And this is the idea that is used nowadays in gene editing to treat thalassemia and sickle cell. Now we come to the update and the Climb 121 that was reported last in EHA. I have explained the idea of the BCL11A. Basically, the function of BCL11A is to suppress the gamma globulin, and this is a natural mechanism that happens in utero and early in the first few months of life. So once this gene becomes active, then you have hemoglobin F, or the gamma globin is suppressed. So this technique disrupts the BCL11 as I showed you, and will allow higher levels of gamma globulin and higher level of hemoglobin F. What is the significance of high hemoglobin F? Is that high hemoglobin F is protective, and with levels of more than 30 or 40, you are resembling a phenomenon that we see in hereditary persistent fetal hemoglobin, and that is seen when the patients with sickle cell and have high hemoglobin F, they're asymptomatic. So with that, this proved to be effective in these patients. Similarly to what I mentioned to you, the way of collecting the stem cell and treating them here in the how to introduce the CRISPR-Cas is through electroporation to create an electric gradient that internalize these products in the cells. And again, similarly, they'll be checking the quality and then frozen and sent to the patient. The same thing, we're using busulfan for conditioning the patient and then follow up on the product. And the design of patients who, for patient with sickle cell, 46 patients were infused with the product. Their ages are 12 to 35 years, and they have all a history of severe VOC, more than 2 per year in the last 2 years. Now, the primary endpoint or primary efficacy endpoint is the patient to have free severe VOC period of more than 12 months. The secondary efficacy point of these patients to have non-inpatient hospitalization. So evaluable patients out of the 46, we have 39 patients. Around 30% of them are adolescent and the rest are adults. The genotype, mostly severe genotype, either SS or S beta 0. They have co-inheritance of alpha globin gene in around 30%. The VOC episodes average of 4 per year, and the hospitalization around 2.6 per year. Now, they required an average of 2 collections per patients, and the average cell dose of stem cell is 4.7 million per kilo, and the follow-up was up till average of around 28 months. The time of engraftment is 27 days for neutrophils, and platelet engraftment of 34 days. Time from hospitalization to discharge is around 1 month, and this is the demonstration of the patients. As you can see, these episodes of painful episodes in these 39 patients evaluable, and then you can see the washout period of 60 days, and then the majority of them did not have any vaso-occlusive disease, 36 of 39. The blue diamonds here are patients who developed, either infections or patients who had chronic pains that come to get some opioids and leave because of their chronic pain. One patient had the bone marrow procedure and developed a painful episode. So these are the complications that were seen, and unfortunately one of the patients developed COVID and died following engraftment. This is the days that were free of inpatient hospitalization, and again, as you can see, this patient who had the bone marrow biopsy, and this patient who had parvovirus infection. Now, the hemoglobin F percentage out of the total hemoglobin was almost 40 to 50%, almost 40%, and that proved to be very effective to keep patients free of symptoms. This is the total amount of hemoglobin, which is close to 13 in both adults and adolescents, and this is the contribution of the hemoglobin F that you can see in both groups. It's very important to have the quality of hemoglobin F in these patients. As you can see, all these patients have pan-cellular distribution. This shows you the qualitative effect of the hemoglobin F that plateaued more than 90% and remained throughout the follow-up period. This is the edited BCL-A alleles, and they were traced and followed both in bone marrow and peripheral blood. As you can see in the green line, these are all have achieved the end point, the primary end point. Those who had blue lines did not achieve it. Yes, they have good allele editing, but they remained symptomatic, and some of the red is still not achieved the end point yet. In peripheral blood, similarly, as you can see, significant maintained BCL editing follow-up. Now, markers of hemolysis significantly dropped in the lactate dehydrogenase, the haptoglobin dropped, and the retic count, in addition to bilirubin. What are the serious or the side effects that we're seeing? It's combination, some of them due to the conditioning by busulfan and some of them due to XSL. As you can see, the serious side effects to XSL were not encountered. The one patient who died of COVID, and this is thought to be not contributory by the treatment. And none of the patients developed malignancy. The other busulfan toxicity, as you can see here, stomatitis, nausea, abdominal pain, etc. Now, quality of life and as is patient-reported outcome was checked by several scales. Some of them pain scales, some of them are quality of life scale. And as you can see, all of them demonstrated improvement after the infusion. The pain scale also showed improvement in these patients. So it's all a positive after the infusion. Now, what about the beta thalassemia? The beta thalassemia, again, the technique is the same. There are 56 patients were infused. All of them were beta zero, almost all of them are beta zero. And the end point, the primary efficacy point is to achieve 12 months of non-transfusion or transfusion-independent period. Again, similar to the other patients, 1/3 of the patients were adolescents and the rest were adults. The genotype is most of them, almost 60% of them are the severe genotype disease, and there are 40% non-beta zero, beta zero. The infusion, the mobilization, one mobilization was required. The cell dose was 8.4 million, and the duration of study was 32 days, 32 months. The neutrophil engraftment was 29, and the platelet engraftment was 43. It took around 40 days from admission to discharge. And as you can see here, patients before the infusion and after the infusion. And as you can see, almost all of them except these two patients extended from the previous study, and they started to achieve some transfusion independence. So 49 out of 52 evaluable patients achieved the transfusion independent period. This is again the contribution of the hemoglobin. Almost 90% of the hemoglobin was contributed by the hemoglobin F, as you can see. And the level of hemoglobin again was around 13 in these patients, both adolescents and adults. The pancellular distribution was same as what was seen in sickle cell, which is really encouraging, and it remained in the straight line. This is the BCL edited alleles, and you can see it's in the bone marrow reaching 90%, and also in the peripheral blood is continuing. Serum ferritin showed significant drop. These patients, after the treatment with the gene, they required chelation therapy either by phlebotomy or iron chelation medication. In fact, 40% of them were able to stop iron chelation after some time. What are the serious side effects? Again, due to XSL, there are a couple of patients who developed HLH manifestation and idiopathic pneumonic syndrome, and another one developed delayed engraftment, thought to be due to XSL, but all of them resolved. On the other hand, the busulfan toxicity was seen in 7 patients that were treated with defibrotide and also deoxycholic acid, and all of them recovered. These are the side effects of conditioning with busulfan. The quality of life, again, similar to what we've seen in sickle cell, all of them indicate positive effect and improved quality of life. And as you can see, all of them were positive. So, in conclusion, for sickle cell, 92% achieved primary endpoint and were free of veno-occlusive disease for 12 or more months. The mean duration of vaso-occlusive crisis were around 28 months, with the longest follow-up of up to 4.8 years. 97% achieved secondary endpoint, free from hospitalization, with a mean duration hospitalization-free period of 28 months. The durable increase in hemoglobin F more than 40% with pan-cellular distribution resulted in a total hemoglobin levels normal or near normal levels throughout the duration of the study. Stable allelic editing in bone marrow and peripheral blood was demonstrated in the long-term stem cell evaluation. Clinical, meaningful, and durable improvement in hemolysis measurements, quality of life was seen. There were no serious side effects related to XSL. Safety profile is consistent with myeloablative busulfan conditioning. So XSL has the potential to provide a one-time functional cure for patients with sickle cell disease. For transfusion-dependent thalassemia, 94% achieved the primary endpoint of having independence transfusion for 12 months or more, and the longest follow-up in this group was up to 5 years. The stable allelic editing of bone marrow and peripheral blood was demonstrated, durable editing throughout the study. Clinical meaningful improvement in the measurements of iron overload and quality of life were observed. Serious adverse reaction attributed to XSL occurred in 2 patients and they resolved. The safety profile consistent with myeloablative busulfan conditioning and autologous stem cell transplant. So XSL has the potential to provide a one-time functional cure to patients with transfusion-dependent thalassemia and sickle cell disease. Thank you.
Thank you, Dr. Abdullah, for a very comprehensive presentation about gene therapy and hemoglobinopathies. In order to save the time, we need just to take on only a couple of questions. So, from the audience, if you have any question.
Thank you, Tom. Nice presentation. This is Dara from King Physicians Hospital. 2 questions. Was there any concern about using CSF mobilization in sickle cell patients? Is it always a theoretical concern? I see you didn't mention anything about the adverse events, so.
The GCSF the plexiform was used for patients with sickle cell disease. However, for patients with thalassemia, the use of GCSF or plexiform can be given, but plexiform was used.
No GCSF in the sickle cell group.
Sorry?
So
No, sickle cell, they avoided the sickle cell not to precipitate crisis in these patients.
Thank you. And second question, the risk of mutagenesis with CRISPR technology. I know that was reported in the other products.
Yeah. Actually, this is a very important point, and I guess as I mentioned to you, this is a point that is of major concern because you're dealing with genes. So the precise cutting in this was looked into by people in this study, and they evaluated several patients, and they didn't see any off-target insertions in this study. And the other gene addition, it's difficult to evaluate. And actually, in the sickle cell group, there were 3 patients who developed myelodysplasia, and there's a questionable AML resulting from this. So again, this is an area of concern, and I think longer follow-up will show, how safe are these procedures.
Any questions?
First, thank you, Doctor, for this nice talk. I just want to ask, who will be the targeted population to use the gene therapy, knowing that our pediatric patients usually doing well with the because we have a match donor or match-related donor in general. Second question, regarding the gene therapy, is it only applicable for those who are having recurrent vaso-occlusive, knowing that our main indication is going to be cerebral vasculopathy in our pediatric population? Thank you.
Yeah, that's a good question. Who's the candidate? That's a very good question. Of course, if you have a fully matched donor, it's out of the question. Fully matched donor will be the patient to have it. Now, alternative donors, one has to look into the outcome and the patient. whether who is he going to tolerate, is he going to develop severe complication, and then probably it will be a consideration for the gene therapy. For the patients with vaso-occlusive crisis, is he eligible or not? Is that your question?
Is there any other indication other than
Oh, actually, this is, again, is a good question. Vaso-occlusive is the hallmark of sickle cell disease. But if you have complicated, let's say, vasculopathy, cerebral vasculopathy, or otherwise, then these patients might be considered for the procedure if they can tolerate the conditioning with busulfan. I guess the question is that who is the best candidate and who can tolerate the busulfan? Okay.
Any questions? All right, thank you, Dr. Abdullah.
Yeah, any other conditioning regimen they've used, or it's only with busulfan?
It's so far they are using the busulfan, and this is a question that was raised. Now conditioning regimen can be, people are thinking of triusulfan as a less toxic conditioning. People are thinking of even antibodies to target the CD, to target the cells. So far, the busulfan is the standard conditioning, and patient has to be fit to proceed with this conditioning.
Thank you, Dr. Abdullah.
Thank
you very much. Now we'll go to the next talk, again by Dr. Muhammad Isa. He will present for us gene therapy experience in Saudi the Kingdom for sickle cell disease and transfusion dependent beta sickle. So Muhammad, mic is yours.
Thank you very much again, and many thanks to Vertex for supporting the talk. And actually, it's great pleasure to follow Dr. Abdullah Jeffrey and make it as a whole a package of the gene therapy journey. And today we'll talk really about some practical stuff that will be raised, and including inclusion criteria and many other related, and the story of the first patient that received gene therapy in the kingdom. So first of all, we'll talk about a little bit of introduction and the journey in National Guard to be accredited as a center, and then we'll talk about the progress as well. This is a repeated slide about the burden of the two diseases that sickle cell is so common, and between 60 to 100,000 sickler in the country. And for thalassemia also it's estimated, of course, less than that, between 5,000 maybe to 9,000, or a range maybe a little bit lower, as a transfusion dependent. Now, as mentioned earlier, the candidate of curative therapy and severe form is about 20%, 15 to 20% of the patients. And this slide I've already shared earlier with the percentage of stem cell transplantation. If you go back on the previous talk and how patients originally, and when this was published as a guideline, for example, in sickle cell patient, who to transplant, and it was dated in 2019, you will see it goes based on the severity, and if there is a donor and there's a matched sibling, then you go for a transplant. Especially if it's mild disease, then it's a question elective you could consider. If it's severe, you will go for it and push for it a little bit more. But if you have a severe disease and you don't have a donor, then you go for the alternate donor. So at that time, the talk was about putting patients on trials for haploidentical transplantation or gene therapy. Now, if we look at recently and how this got evolved after the study's been elegantly illustrated by Dr. Abdullah, and all the outcome in regards to the XSL, It was FDA approved, or like it was approved by the UK earlier, and then in the FDA by December 2023, followed by the Saudi FDA in January 2024. Now this is a big move because it is changing the landscape and the movement and how to approach those patients, and it opened a track for many patients who are suffering. And as illustrated earlier, using CRISPR-Cas9 gene editing approach in that situation in XSL is just to direct BCLA11 and knock its function, in other words, and remove the repression pathway, and then hemoglobin F will be raised. Now, this pathway in sickle cell, you will go up to 40-50%, but in a thalassemia patient, you'll probably be 80 or 90% hemoglobin F, and then you'll be transfusion independent. And those are certain of the endpoints that was talked about, and it's already been illustrated very well about the value of hereditary persistent hemoglobin F and whether that could alleviate the vaso-occlusive crisis in sickle cell. So from there, the work to transfer and go through that kind of treatment and cellular therapy in the institution started earlier, after the fact aggregation, but late in 2022, we started to work with some quality work between the groups in the adult hematology stem cell transplant unit and the pediatric, the stem cell lab, and the apheresis team, and a lot of support both ways from the Vertex Pharmaceuticals as well as the administration support and the KMARC, because there are a lot of interactions between the groups. So as soon as we were almost there, we knew that it's going to be approved by the Saudi FDA sooner or later. And then as soon as then that multiple visit mocks has been done until we got the approval to go through the journey, as you saw then illustrated earlier, from the collection to transferring the product to bringing, taking care of the product, retransfer it back, and then later on conditioning the child or the patient and infusing the cells, and follow up after that. So the first patient was collected in February is a transfusion-dependent thalassemia patient, a 12-year-old at that time. Now he's 13, almost. And the first sickle cell patient was collected by our adult colleagues in March as a starting point, who requires multiple collections, because the difficulty in sickle cell and collection is more than the thalassemia. While in the other way around, we think, and as per illustrated in the data, complications for thalassemia during conditioning and after conditioning, like VOD, is higher in thalassemia patient and need to be worried about or be careful about, similar to transplant patients. Alhamdulillah, 14th of July, the first patient was infused, but we'll come into details and describe you certain things during that time and how we try to select those patients and who are the candidate, because that was a main question from the audience. So in the hospital, we had also multiple meetings, and I believe a lot of support and a lot of discussions, and it will be also with the National Collaborative Group later on and see how things will go. But we elected at the beginning to follow the SFDA approval. So it has to be an age above 12 years. So 12 to 35 is our criteria. We currently, the subjects are severe sickle cell. So, and we defined that by recurrent VOC more than 2, per year in the last 2 years, requiring hospitalization, despite using hydroxyurea and other things. So indications that it is severe, and also recurrent acute syndrome as one of the main indications, or severe disease that's causing ICU admissions and frequent exchange. Now we have to put in mind, because it goes through certain things similar to transplant. Patient has to have a good performance status, good Lansky, good performance, and could tolerate the process, the whole process. In addition to that, we've put some help, or like a kind of exclusion criteria at the moment. You know, all what I'm talking about is dated today, so maybe it may change in the future, and there are a lot of things that change depending on the outcome and many other things. But if we have available, as mentioned by Dr. Abdallah, that a matched donor, 10 out of 10, will go for a transplant rather than a gene at the moment. Other exclusion is a prior transplant, prior myeloablation. So, this is one of the things, at least at the moment. And a clinically, of course, significant active infection or so, that will make the patient at high risk during the procedure. Now, there are other things that very logic, like unavailability of blood product and severe aluminization, that you cannot have some transfusion during the conditioning or post-conditioning regimen time, or patients like in the study who have severe chronic pain in sicklers, that you sometimes more than 10 unplanned hospitalization, that you worry that it's not only about the sickle cell and the vaso-occlusive crisis, but it's more of a chronic pain that may affect the outcome as well. Now, I put in red two things, and those, we need more data about it, and at the moment we are not going there yet. Now we can't say that you cannot do it, but at least in the studies and in the inclusion criteria in the study, those patients were excluded. So patients logically with persistent fetal hemoglobin, especially in the eastern region, they are needed to be studied further. The presence of vasculopathy, particularly moya disease, need to be also tackled more to study before going it and putting it as a standard of care. The other exclusion are things that you have also to be careful about, similar to a transplant: severe advanced liver disease, someone who has cirrhosis, or a GFR less than 60, or a very severe lung dysfunction or restrictive disease that you cannot go for busulfan. So there are other things that is, heart disease. So there are things that is similar to transplant that we cannot proceed with gene therapy at the moment. On the other hand, if we look to TDT patients, transfusion-dependent thalassemia, we also have to make sure those patients really transfusion-dependent thalassemia. So they have a lot of transfusions, and based on we put the criteria that usually is for beta thalassemia major, what we called in the past, or intermediate that are on very regular transfusion. And if you see in the study, there are some of them were beta 0 and some of them were beta plus. Also similar to sickler, they have to have good performance status, good organ function. Similarly, we particularly focus here on iron overload in thalassemia patients. We also have to focus on it on sickle, but in thalassemia it's more obvious. So looking at the cardiac and the liver MRIs, we have put the function, if it's less than cardiac T2 star less than 10 milliseconds, then this is kind of exclusion. We also mentioned the other liver dysfunction, etc., as not fit for the conditioning. And if the liver iron concentration is more 15 milligram per gram dry weight on T2 star MRI, you need to be cautious and bring it down prior to conditioning. So similar to sickle, the presence of HLA matching. The others are very similar. Other exclusions like significant bleeding disorders, active malignancies or history of restrictive lung disease, GFR less than 60, and active severe viral infections, HIV, etc. The other part also that was already raised is how to collect those patients. And GCSF is something that, as mentioned, it's not usually used or deemed as contraindicated in the protocol because of the propensity in sickle cell patients to cause a crisis. Now, we know that CD34 cells, it get lower by age, and if you are a sickler and you have a lot of crisis, etc., you probably have an abnormal bone marrow. So the bone marrow will not produce as much as you would expect. So to prepare for mobilization, and this is one of the major challenges, because we are reaching around 8 patients, mainly in adults and 2 in pediatrics at the moment, between sickle cell and thalassemia. There are preparative things that you would do prior to doing that. I would start first with the sickle cell, because it's first here and it's the most common in our country. So those patients, there are certain things like stopping hydroxyurea around 8 weeks prior to the collection. And then you start those patients on those who are not on regular transfusion, and most they're not, because you're not taking the stroke patients. So you will initiate exchange transfusions for those patients. You want to keep the hemoglobin between 8 and 11 and do exchange. And then you do the last one during that period, 3 days prior to the collection. And then you give Prelexafor for 3 consecutive days, and each day you will collect. Prelexafor in sickle cell, you give it around, in our protocol, 3 hours prior to start the collection time. And that you don't want to miss the peak of the collection, because it has been seen in the studies, and in the original study it peaks around 4 hours, 4 to 5 hours post the giving Prelexafor. The other thing is you try to avoid those patients from crisis and acute syndrome, because in the studies and per communication, some of those patients, you start them on GCS, on Prelexafor and mobilization, etc., and you don't want them under the stress to get a crisis. The good thing, you already have done exchange transfusion, etc., so that's already helping. But on that, some protocols in sickle cell, people would give anticoagulation prophylaxis. So whether enoxaparin or aspirin, it depends on the center preference, and it's not mandated. Those all helps to motivate and increase the yield of the collection, because you want to reach around the maximum that you could get. The target is around 15 to 20 million. If you reach it, that's good, because 15 to 20 million per kg of CD34 is not easy to get. And our colleagues in the apheresis and stem cell lab, each cycle, each time you get collection, it's not 1 day collection. You do the first day and the second day. The third day is a backup in the first cycle. We call it a cycle with 3 different collection times in the first attempt. So as mentioned, it's usually the range between 1 to 6, and the median is around 2 cycles is needed for any sickle cell patient. And from our experience, they are variable in the adult team. Some patients are needing more cycles than the thalassemia patient, because we saw the difference. So in thalassemia, it's the other way around. They are already receiving transfusions because of their underlying disease. They are not on hydroxyurea. They can get GCSF. So you mobilize them like transplant patient. You start with GCSF 4 days earlier. The only thing you need to put in mind, if you have a splenectomized thalassemia patient, then you need to adjust the GCSF to once a day, or like half dose, so 5 mic per day instead of the 10. And we give the Prelexafor 4 to 6 hours this time in thalassemia patient per protocol, and usually they require 1 cycle. The average is 1 to 4, but 1 is usually enough. And with our 4 patients who are collected, all got 1 cycle. So a lot of work early AM apheresis, because the cells need to be shed and go in a fresh daily with a flight to the manufacturing or treating facility in Europe. And that logistics needs to be really arranged, and thanks to all the people who are involved in this process. Now we can give you a little bit of more of a clinical outcome for the first patients that was done in the pediatric, who is a 12-year-old and now 13-year-old. He's a beta thalassemia patient who ended up by regular transfusion program lately every 3 weeks, has got iron overload and referred to us for transplantation. This patient unfortunately did not have a match donor and neither match unrelated donor, and started to accumulate iron. The ferritin was in the 3,000 range plus on iron chelation, and was following rigorously after that referred to us for transplantation. So we received this patient in February, collected him, and one-time collection was enough to one cycle to ship the cells, and we got the great news after that cells are enough, and the quality checked has been give us a green light that there are a lot of work and quality to make sure that the cells are adequate and of good quality. So once we received it end of June, we started the patient on conditioning regimen. But before that, we reassessed the MRI to the T2 star again. So the iron concentration went down from 10 to 6 milligram per gram per milligram dry weight. And the cardiac MRI was always good, above 30 milliseconds with a good ventricular functions. The ferritin was actually in the range of 2,000 or so. And this feral was stopped. So we had actually, during the time of manufacturing, we were able to intensively chelate the patient with differiprone plus like dual therapy with differiprone and desferal. And we made sure that the pulmonary functioned well. We give the 4 days busulfan with Q6 hour doses. You have the options of doing once a day or Q6 hours dosing. We are more used to Q6 hour dosage. We have increased the dose of busulfan from 0.8 milligram per kg per dose to 1.1 milligram per kg per dose. So it's like total 4.4 milligram if you give the once a day dose. And we targeted around 70 milligram per liter. Now the original study target between 80 but the data of the study for the Q6 hour dosing, 70 milligram is acceptable. This is the big bucket where you have the cells, and those are the 3 vials that we received. So it could be 1 vial, it could be 9 vials. We have received 3. We had on them 12.2 per kg, millions per kg of CD34 thawed, infused, day 0. And during the pre-engraftment period, so in 14th of July until the engraftment, patient had the usual neutropenia, cytopenia, mucositis, and the patient had a mild VOD, but a little bit late. Everything was shifted. It's like the myeloablative transplant. It's like 7-8 days after you see the drop of the cells, like reduced intensity and other, but it's with busulfan. So we started to see the drop after day 7 or 8, and we were like, is it working? Like the chemotherapy, it's always there, scary for the first patient, and especially patient accepting to be the first to be treated with such therapy in the center. Now, for that reason, they put the patients on defibrotide, and the patient was tolerating that, and diuresis, and patient recovered from that very smoothly. Neutrophil engraftment was a day plus 25. Last transfusion was day plus 32. It was before, but they transfused before I told them. It was like 8 point something, like 0.9, the hemoglobin. I thought we should just go to 8, not 9 as a threshold, but anyway. We added 7 days for the platelet engraftment. And the patient was discharged. And the last transfusion was given, that PRBC transfusion was around day 21 or so. So it's around more than 6 or 7 weeks now from the last blood transfusion, where the patient were receiving it every 3 weeks prior to the procedure. Interestingly, the hemoglobin F we wanted to check because that's the marker that we are looking at. So at day plus 52, it was 31%. Beginning of this week, on Sunday, was 42%. We're seeing it nicely coming up. And the patient is being followed closely. We are hoping that we will resume iron chelation in a while. At one point, I did the ferritin. I saw the same curve and I got scared after like a transplant or like it went up to around 10,000 plus. So it's an inflammatory marker. It's nothing, but it is exactly the same as the figure showed by Dr. Abdullah, that there is a peak and it's coming down. Really, it is a benefit and risks, and the difference between gene-edited and stem cell transplantation or allogenic stem cell transplantation, because these are autologous edited cells, is the conditioning regimen, the type of transplant, the GVHD risk, post-transplant care, return to work or school, quality of life. All these are factors to be considered, and also the number of patients, the cost, and many other things. We know there is no GVHD. We know donor availability is not needed in gene therapy. And so far, from the few numbers of patients that have been published, graft failure is not a big issue, but long-term follow-up is needed. We have to keep in mind also transplant-related complications, whether with gene therapy, with the current busulfan-based conditioning, or in the future if it's going to change, because that may play also a different role in choosing, infertility risk, and the risk of disease progression with age or long-term follow-up and the unknowns. So to conclude, we know that allogenic and gene-edited therapy are changing the natural of sickle and thalassemia patients. Gene-edited therapy has the potential to overcome many limitations with transplant, like lacking a suitable donor, a GVHD, and the need of prolonged immunosuppression, and easy go back to work and school. Very promising experience for the first patients in regards to mobilization and treating. We still did not infuse the first sickle cell, but also we are willing and to see how that goes. The limitation of gene-edited therapy studies are very clearly. There's a small number of patients around the world who have been treated so far in clinical trial, and a shorter follow-up, and really a national approach and support and collaboration is really warranted between all the aspects. Let's remember, there are many corners here: the patients, the clinicians, the laboratory services, the logistics, and the decision maker, the Saudi FDA, the Ministry of Health. There are a lot of people that are working together, hopefully, in the future for a better future, to lead this particular part in the country, and contribute to the international community, and for those patients with hemoglobinopathy who are really usually suffering in many different areas in the world. Before forgetting, this is a barcode. Please, if you could screen it, you could also evaluate the session. It would be great. And thank you again for having me here for a second talk, and I'll be happy to take questions.
Thank you, Dr. Mohammed. That was really fascinating. Thank you very much. Now we leave the audience for if they have any questions.
Thank you, Mohammed, again for excellent presentation. I have a question for the mobilization when you reach 15 million per kilo. You said that, and then like you get it's not enough, and I assume that you sent 15 million per kilo.
Sure.
How does it go?
Okay, so currently we are following an exact, a certified approach that also will be monitored by our colleagues in Vertex to make sure everything is going through the process. The target, as you mentioned, 15 to 20, but we collect per cycles. So the first 2 days must be collected. The third day we collect because it's the backup cells for autologous recovery or for any reason that we need a backup cells. For the second cycle, we only need 2 days. For those days, every time we ship, so we will ship the 2 days in a row. We will have our quality check in our fabulous stem cell lab. They will tell us the cell dose, etc. But we go usually the maximum for those 2 days. With a maximum, we put around 500, I think, the ml, but also with a maximum volume, usually in the adult is 4 blood volume or so. And then those cells will go, and sometimes they exceed, as you mentioned, in thalassemia, they are good mobilizer. So we have the second patients around 50 million reach there. But not all the 50 million will come back to you because they will be edited and they will have quality checks, and some of the cells will just not be stable to come back to you in the good maximum shape you get. So to start to get manufacturing, they are talking about 15 or 20. I mean, there are different talks about it. But what to infuse, you don't need that. The median is like 4 or so if you look at the studies. So whatever you get later on, it's fine. But just to start with over there, they want to start with the first. If you, let's say, you get a borderline, then it will be a discussion between the team. But usually they will say, just follow the protocol. We need above this limit to start working. And then they start working on a batch, and then the other batch after that, I believe.
Do you have to give GCSF after the infusion? Or you just wait for natural?
Sure. So in the study, 60% I think they got GCSF in the thalassemia patients. We did not. Our patient, we did not give it. We waited a bit, and our cell dose was good, actually. Patient had some VOD. We did not want to flare up anything, so we just left it. We gave the patients, another week or so to see if we will give 1 dose of GCSF or not. We were still less than the median of the publication. I think it was 29. We engrafted 27 days. And the previous day, we were seeing the white blood cell is coming up, but not yet engrafted. So we kind of wait on that patient. But again, with time, we still don't know on the sickle cell. We'll need to learn more about it. And even with more patients with thalassemia, I think time and more patients, we are learning from each patient that we do at the moment, and all through those steps. In regards to collection, the line used, the exchange, how to do the exchange, all these things are things that we are trying to build our own experience and share it with everybody. And I'm sure it will happen with all the hospitals around the world and our colleagues in King Faisal.
How do you define the persistent hemoglobin F? Genetic or just numbers?
Okay. So in the criteria that we put, we did not put genetics. We are not doing genetic testing for hemoglobin F. We are just measuring the level. For sicklers, when I sat with Dr. Mahsen, we put 30%, above 30 or less than 30, but for the inclusion, but we did not, commit at the end. But we put the 30%. In terms of genetic testing, we made sure in our patients that if for beta and alpha, I know it was mentioned, it's not needed, and we are not mandating it for the alpha thalassemia gene check, but for thalassemia because of the other products, but we have done it as part of the academia to check our patients. So the first patient was negative in thalassemia patient, and the second one has 1 alpha deletion, which is not an exclusion, even in the gene addition way.
Thank you, Dr. Ahmed, for this nice presentation. I
I will ask about myeloablation protocol in a sickle cell patient. Could we use another myeloablative protocol other than busulfan, as this patient may have later on myeloid malignancy, may be related to gene therapy or may be related to busulfan? So is there any study using other myeloablative protocol other than busulfan?
Sure. So, so the publication and all the data comes with busulfan as a conditioning regimen. This would never happen without a clinical trial, I guess, because of many logistics and many things in regard if it's going to work or not. So, in the future, I'm sure, but it is when and how and who, and it depends on what product. Other alternative, like Dr. Abdullah was mentioning, TREO or antibody-based regimens will be studied, but we do not recommend to use anything different at the moment until we have really get it under a clinical trial. Yeah.
How do you address fertility?
Sure. So this is similarly to what we are doing with transplant in pediatric patients. We tell them clearly, and unfortunately, if you are going to this pathway, if you don't have the facility to fertility preserve, then this is something that there is a high risk of infertility receiving busulfan. Now, what are the numbers and etc.? Most of the data comes from the transplant, but it's usually a combined kind of thing. So bucide, buthiotepab, but again, exact number we don't know. But in the literature, you always talk about those category busulfan above 80% or above 60%. This range, it depends on the myeloablation and BRCA and other things. But this is based on very old studies and combinations. But we tell them that, if you are going for that, then that's the thing. Now, this is mainly in pediatric and prepubertal. Let's remember this is approved for until the age of 35. So it is already available. Sperm banking and oocyte preservation is available. So the only thing that we don't have is ovarian tissue and testicular tissue. Testicular tissue is experimental, and for ovarian tissue, it is being done in countries, and I'm sure there are projects in the future to have it here.
Thank you so much, Dr. Mohammed. Actually, I have two questions. The first question about your patient. We'd like to know what was the baseline hemoglobin F. And second question, maybe for Dr. Tawfiq. We know that sickle cell disease is a multi-system disease involvement. So we saw very dramatic functional improvement in terms of vaso-occlusive crisis. What about the subclinical issues like growth, development, LH, FSH, DEXA scans, and subclinical CNS complications? Thank you.
Sure. Great questions. The first question is easy. The second question I will address. The first question is, the patient has been already getting transfused regularly every 3 to 4 weeks. So where their electrophoresis is basically the transfused blood. So it is low and transfused blood. We are not targeting here just only a percentage of hemoglobin F. It's a pan-cellular hemoglobin F with a rise in hemoglobin. So the patient did not drop the hemoglobin. Now the hemoglobin is ranging. Now we are at 2 months. It's around 11 to 12, 11.5. If you look at the study, they'll go around 12 and continue at 12 without transfusion. We have good signals, LMMLA. We don't know the future. But we are not doing the allelic ratio testing or like the testing exactly the gene-edited cells. But this is something that we have to look at it in research setting. In terms of sickle cell, I don't really have the data as many people, as the studies has only mainly, if you look at the end point, is vaso-occlusive crisis. We still have a lot of things, but we could think and extrapolate that things will get better. Not everything, but there are secondary endpoints. But if you are talking about moya disease, we cannot have any, clear um, I would say, conclusion or extrapolation, because let's remember, moya moya is not only hyperinflammatory and only sickle cell related, it's also already a mechanical damage has happened. So it's currently it's excluded, but you know, if we think that high hemoglobin F will reduce that or reduce the inflammation, I mean, it would reduce, you will have less sickling, so you're likely less attraction of WBCs and other inflammatory markers. So probably other markers will get better, but it needs to be studied in the long term. Now, long term about DEXA scan, osteonecrosis, and other things, I really don't know, and we need to follow it as a whole community.
So, one question over here.
Yeah.
With the price tag that comes with this technology, do you think it's worth? Do you think it's worth, especially with some of the concerns that were shared by the colleagues, doing a baseline whole exome or whole genome for these patients, just to have this in the archive? Should hematolymphoid, especially myeloid malignancy, develops, we can maybe contribute this to something that is not that was not instigated after.
Yeah. And certainly, any studies or additional data, and so people are doing it. You know, archiving some DNA and other things longer follow-up, other markers. All these things could be, you know, stored, biobank it, and maybe later on some of them also could be explored or on the spot. There are other databases that we are looking into that. Now, in regards to I agree with you. I mean, in regards to the cost, you know, there are two or three things, and we put in mind the long term and the pricing and the cost effectiveness and the number of patients and access to care and all these things should be on the table all the time with any patient. So similarly to transplant as well, in terms of availability, quality of life, and other, and GVHD, etc. And at the end, I mean, time will tell us where we're going. At the same time, I don't think also once more editing of cells, more people are doing it, even cost with time might go down as well. So it is a very sophisticated, I mean, you know, being a hematologist outside CRISPR and gene editing and precision medicine, it's a totally different thing and scary. And once we learn about it more, it's just something that we, you know, we are learning with time.
Okay, thank you, Dr. Mohammed, for your talk. And here we conclude for this session. We'll have our coffee break for 15 minutes, then we'll come back for the final session. Thank you very much.
Thank you.
Professional Murphy, she is a consultant hematologist and a senior lecturer at the King's College and King's College Hospital in London. Dr. Pramila, she works as a full-time NHS consultant with a special interest in MDS, stem cell transplant. She has a special interest in the field of immunotherapy of myeloid diseases. She will talk about transplant in MDS today and under the title of Optimizing Transplant Outcomes for High-Risk MDS. Dr. Pramila, the floor is yours.
Thank you very much, and thank you for the invitation. I'll just turn off my camera whilst I'm presenting. So these are my disclosures. So I think that we have seen over the years that transplant has become an increasingly used modality of treatment for patients with MDS, as we have accessed more reduced intensity conditioning based transplants, which have therefore allowed older patients who make up the majority of patients diagnosed with MDS to actually proceed to transplant. But as you can see from these two retrospective studies, on the left from the EBMT and on the right from the CIBMTR, you can see that the major problem, the major cause of treatment failure for allogeneic stem cell transplant for MDS is that of relapse, with significant proportions of patients succumbing to relapse, at least 30%, if not slightly higher. So in terms of trying to optimize transplant for MDS, really, I think I will focus in this talk mainly on the disease itself and how we can try and control this. So, as you, I'm sure, would expect, there are essentially several points where disease control in MDS is relevant and would have an impact on transplant outcome. So we have the pre-transplant disease status and treatment, what the role of conditioning is, and finally prevention of relapse post-transplant. And all of these separate stages are impacted upon by factors such as patient selection and fitness, disease risk stratification, donor availability and selection, preventing NRM, and supportive care such as microbiome interventions, which are increasingly being explored. So I won't be focusing on the wider areas which are more cross-cutting, but on these specific areas. So I'll start by talking about pre-transplant disease status and treatment, and essentially how much disease control pre-transplant, how much does that affect outcomes? So I think over the years there's been some debate, and this continues to persist, about how much cytoreduction is essential prior to an allogeneic stem cell transplant for high-risk MDS in order to improve outcomes. And these are some data which were published back in 2019, and this was a retrospective analysis of 165 patients with MDS EB or secondary AML, and looked at their outcomes according to their treatment pre-transplant. So around 40% had had upfront transplant, a similar proportion intensive chemotherapy, and then about 20% had HMA-based treatment prior to transplant. And in terms of the blast percentage, the upfront patients all had more than 5% bone marrow blasts, and then the intensive chemotherapy patients, 59% had achieved CR, and with HMA, 18%. So when you look at their outcomes, you can see that according to these data, so even taking patients with upfront disease, no treatment, and more than 5% bone marrow blast, their outcomes seem to be similar to those patients who underwent both either intensive chemotherapy or HMA with similar relapse-free survival. So these data suggested that perhaps for these patients with MDS and an increasing blast, maybe control of the disease and cytoreduction was not essential. However, there have been other studies which have contradicted this. And for example, in this retrospective study from the States, and if you also look at the currently still looking to fewer than 10% bone marrow blast prior to transplant to improve the outcome. So the question then arises as to how we should cytoreduce in high-risk MDS pre-transplant. And as I've already alluded to, there are very few randomized control studies that have been published. One such study which is currently recruiting is the ACROBAT study, which is from Gitmo in Italy, from the Italian group. And this is a phase 3 randomized control trial, which is looking at what happens to patients who receive HMA and go to transplant versus upfront transplant. So this is only for patients with fewer than 10% bone marrow blasts. And if they have higher than 10% bone marrow blasts, they are randomized either to HMA or intensive chemotherapy. So that could be an interesting study for us to learn from, and the results are awaited. And then the question should also be, what are the objectives of cytoreduction? So what are we aiming for in these patients? It's somewhat different from acute myeloid leukemia, you might argue. We could reduce the blast percentage to below 5 to 10%, but exactly how low? We could reduce mutational burden. We could even go so far as to trying to reach an MRD negative state. But how much will this influence the outcome? And what would be the challenges and toxicity of trying to achieve such deep response? We might also be looking to try and reduce marrow cellularity in these patients who are often hypercellular, but we also often want to improve or control the disease burden whilst a donor is being identified. And certainly cytoreduction could be more relevant in the context of reduced intensity conditioning versus myeloablation. But given the majority of patients will undergo reduced intensity conditioning, perhaps it's something that we really do need to understand better. And there are potential disadvantages for proceeding to cytoreduction, including failure of therapy, and perhaps then a patient becoming deconditioned or having resistant disease and ultimately not reaching transplant. Of course, we may, with our chemotherapy pre-transplant, select resistant clones within the MDS, which then cause problems post-transplant. And we know that you do accrue complications and side effects with many of the drugs available to us, such as fungal infections or cardiotoxicity, and these may be more so with intensive chemotherapy, although even some of the non-intensive approaches can cause considerable problems. So what studies are there that have looked at debulking pre-transplant in high-risk MDS? So these are a few of the retrospective, mainly registry studies, a few single center, which have looked at the impact of the pre-transplant intervention, usually either intensive chemotherapy or HMA, on the relapse-free survival and overall survival. And when this type of analysis has been done, essentially most of these studies have not shown any clear difference for either approach. And of course, it is difficult with registries to understand exactly why a particular treatment was chosen by the physician. There are many biases which could be occurring. So therefore, what about prospective trials of debulking pre-transplant? And there have been some of these, although they are generally somewhat difficult to conduct. If we look at the first study, which was carried out in the States, unfortunately, this had to be terminated due to low accrual, but was looking at patients who are MRD positive with AML or MDS-EB2, who are MRD positive following induction, and then looked at either taking them to transplant or having further CPX-351. Alternatively, there are some other studies. The second one is not yet reported that I could find, which was looking at HMA versus intensive chemotherapy in MDS-CMML with EB 5 to 20%. Then there are a couple of ongoing studies, ACROBAT, which I've also mentioned already, and PALOMA, which is a German-Austrian collaboration and is looking at oligoblastic AML, so including MDS-EB2, effectively, and looking at the role of CPX-351 for up to 2 cycles versus either DA or HMA prior to transplant. What we do have are some data from this clinical trial, which was a prospective clinical trial led by Nicholas Kroger. And this was a German study that was actually geared to looking at the role of treating patients either with 5-azacitidine or with transplant. So the question was not specifically about the type of induction pre-transplant, but it's possible to draw some important pieces of information from this study. So these high-risk patients by IPSSR all commenced azacitidine, and then responders after 4 cycles were randomized to transplant if a donor was available or to continuous azacitidine. And whilst there was an event-free survival benefit for patients who went to transplant, there was no overall survival benefit for transplant. The CR rates were only about 14% overall, and there were several PRs, and stable disease was also very common in 50%. But the important point to note was that there was a very high dropout rate of about 1/3 of patients who either died or progressed during cycles 1 to 4 of azacitidine. So equally, if we do decide to give pre-transplant treatment, we should be aiming to get to transplant as soon as we are able, because we may lose patients on the way. And then if we think about our current standard of care, at least in the UK and in several countries around the world, the standard of care remains HMA, so azacitidine, as a treatment for high-risk MDS. And we know that the response rates are both short-lived and only about 1/3 of patients will respond. So, and in terms of CRs, the CR rate will be lower. Therefore, many groups and drug companies have tried to look at what the impact of adding another drug to HMA backbone would have on improving responses in high-risk MDS. And as I'm sure many of you will be aware, sadly, this has been a graveyard over the years with no real advance and several drugs falling by the wayside. So in terms of ongoing phase 3 trials looking to improve on azacitidine, I think we are all still eagerly awaiting the results of Verona, which is randomizing venetoclax and azacitidine versus azacitidine in treatment-naive high-risk MDS. We also await the phase 3 for Stimulus, looking at the role of sabatolimab, and currently progressing is tamibarotene, which has reached the point of interim analysis. And there's another study, Ascertain, looking at the role of the oral decitabine cedazuridine compound, ASTX727. So we still have some hope, although history unfortunately has not proven favourable for high-risk MDS. So what data do we have for the role of venetoclax in high-risk MDS pre-transplant? There has been a phase 1b study whilst we await the results of Verona, and data were presented at ASH last year. And you can see that these patients were adult de novo patients, 107 patients treatment naive with high-risk MDS, IPSS score at least 1.5 or IPSS greater than 3, with less than 20% blast at baseline, who went on to venetoclax given 400 milligrams orally daily on days 1 to 14 per 28-day cycle with azacitidine. And there certainly have been promising results reported for this combination, with a overall response rate of 80%, including CR and marrow CR as well as PR. And the median number of cycles that patients had was 4, and the median time to CR was around 3 months, suggesting that this can work quite quickly to get patients into a good remission, and noting that this was quite a high-risk population group. So 86% had high or very high-risk IPSSR, and 90% had more than 5% blast. Median duration of CR in months was 16.6, and about 40% proceeded to transplant. So, as I mentioned, we await the results of Verona, which again uses the same schedule of 14 days of venetoclax for both transplant eligible and ineligible patients. And it will be interesting to see the CR and OS from these rates from this study, and the rates of movement to transplant in those who are eligible. So if we continue to understand again how important the depth of disease control is pre-transplant, and if we accept that fewer than 5% bone marrow blasts are preferable according to the ongoing practice, ELN 2017, etc., data suggests that we should be trying to get the bone marrow blast down. Then the question then remains is how deep should the remission be? And obviously in AML, MRD has become increasingly a utilised modality and is now starting to guide treatment decisions, but less so as yet in MDS. And this is a study which was one of the earlier ones to look at the role of what they called minimal identifiable disease by either cytogenics or FISH, or by flow cytometry. And what you can see is essentially that there is more separation here in the curves for the reduced intensity conditioned patients. And so there is a suggestion that perhaps, at least in certain, with certain conditioning types, and probably with certain types of disease, that the depth of disease control could be relevant. And subsequent to that, we've seen much more detailed and precision-based analysis by looking at the role of NGS-MRD. So this study from Chris Hourigan's group has looked at in patients undergoing transplant within the BMT CTN 0901 phase 3 trial of conditioning intensity in MDS. This looked at pre-transplant blood samples from MDS patients who had fewer than 5% bone marrow blasts, so 48 patients that were studied, and 42% of the patients had mutations detectable on their pre-transplant sample. And if they were positive, then they had a significantly increased rate of relapse, so a 3-year relapse rate of 40% versus 11%, and decreased overall survival. And certainly there appeared to be an impact of conditioning on this, in that there was a lower rate of relapse for the NGS MRD positive MAC patients, myeloablative patients, versus RIC. So I think over time, as the technology advances and as we learn more about it, the use of MRD and understanding better the degree of disease control required will help to guide our strategy to improve our post-transplant outcomes. What about conditioning, and how does conditioning intensity affect relapse-free survival in high-risk MDS? So essentially, the two studies that have provided us the most information on this topic have been the US study led by Scott, the BMT CTN 0901 that I already mentioned, and then Kroger study, which looked at MAC versus RIC in a European multi-center study. And the two studies were somewhat different. They included different patient groups. And in the MDS patients, these tended to be a much smaller subgroup of the whole population, particularly in the Scott study. And therefore, it was underpowered to specifically address outcomes for the MDS group. There were differences in the choice of MAC and RIC conditioning across the two studies, and they had different primary endpoints, which means it is somewhat difficult to completely extrapolate between the two. Although the Scott study essentially suggested that the patients who received a MAC had superior outcomes compared to those patients who received a RIC transplant. But pointing out that the TRM was very low in that study, at 16% for a myeloablative transplant, 4% for a RIC, and was higher and perhaps more, as we are used to, in the Kroger study. So all of these factors could be affecting the outcomes. The longer-term follow-up of the SSBMT study confirmed the original findings, and it does seem likely that higher intensity might be necessary in higher risk patients based on some of the NGS data I've also shown you, but a caveat may remain P53 mutated disease. However, in the UK, we carried out a study called Figaro, which looked at an augmented RIC regimen, looking at the use of Flamzabu ATG RIC compared with standard of care RIC in patients, again, with AML and MDS, so MDS being a subgroup within the AML population. And this study did not find any difference in overall or event-free survival for the use of an augmented RIC regimen, although there were some interesting findings about the potential for conversion to full donor chimerism to overcome MRD positivity and its impact pre-transplant. And so there are other studies that are also pending, including COSY, which is another UK study which is a phase 3 randomization between the use of TBF versus fludarabine busulfan-based conditioning in patients that includes a group with MDS with high risk. So the results of that are also awaited. And there are currently recruiting studies of novel conditioning regimens listed here. This is just a selection. And of course, venetoclax is being combined with our standard chemotherapy drugs in some of these studies, but there are also other studies looking at a range of well-known options and trying to evaluate them against each other. The last study at the bottom is not so much a conditioning study, but it is a formal randomized evaluation comparing the role of ATG plus cyclosporine and MMF as graft versus host disease prophylaxis versus a PT-side-based regimen in patients undergoing matched unrelated donor transplant. And this is called MOTD and will include some patients with fewer than 10% bone marrow blasts. So finally, in the last section, how can we actually try and prevent relapse? And how can we identify those patients who are at the highest risk of relapse? So we know that the IPSSM itself could better predict transplant outcomes than the IPSSR. We know that from the original data set that the IPSSM was developed in, and in a real world validation of the IPSSM in 964 transplant patients, 204 were upstaged by the IPSSM and 229 were downstaged, and the IPSSM was significantly better at predicting overall survival and relapse-free survival than the IPSSR, although you can see that there's still some degree of lack of separation at the bottom of that curve on the right. We know also that monosomal karyotype independently predicts for poor outcome following transplant, with dismal long-term survival of around 10%. And very high risk of relapse. And therefore, identifying some of these patients who we know will do particularly poorly will either suggest that we should have aggressive strategies to prevent relapse post-transplant, or perhaps suggest to us that transplant will be futile. And this is where perhaps the discussion around P53 comes in, although there remains some controversy here as well. So these data from Coleman-Lindsley from back in 2017 were some of the first to really show us that patients who had P53 mutation, whether they were young or old, whether they had a RIC or a MAC transplant, did very poorly, with a 3-year overall survival post-transplant of only 20% surviving, and a median overall survival of under a year. And there are other gene mutations that were identified in that study, including RAS and JAK2. And we know that P53 mutational state is complex, and it's not just whether you have or don't have P53 mutation, but is this a monoallelic or a biallelic abnormality? And as I'm sure you will be aware, that there is clear definition as to the TP53 multi-hit state, and trying to understand whether someone has monoallelic disease or whether, based on both karyotypic and or also gene mutational changes, whether someone has either a single hit to their P53 or more than one. And Elsa Bernard's data now from back in 2020 demonstrated the adverse survival for MDS patients with a multi-hit state, whereas those patients with wild-type disease appear to have perhaps a similar outcome as the mono-hit patients. However, there have also been other studies looking at the impact of P53 status, and these have not necessarily shown a difference in the same way for single versus multi-hit. Either way, we know that this is often associated with complex karyotype, for example, or other adverse prognoses, such as monosomal karyotype. So if we're going to try and intervene with patients post-transplant, we need to have better ways of trying to identify disease recurrence early, because once patients' disease is returned, we know that their chances of long-term salvation, long-term salvage goes down considerably. And so these are some retrospective studies that have looked at MRD monitoring post-transplant for high-risk MDS. And essentially, they have tended to use different modalities. So in the top study, multi-flow cytometry, the Dunkervag study from published in NEJM in 2018 looked at NGS. And Nakamura more recently published the use of a personalized ddPCR assay to monitor patients undergoing transplant. And essentially, all of these studies have shown that pre-transplant MRD can be associated with positive MRD can be associated with relapse. And secondly, that there are that having MRD positivity early on post-transplant is associated with higher risk of disease progression or death. And so there are several studies now that are showing that MRD could be predictive. And so this is another study that has also demonstrated that prospective monitoring of MDS, NGS, MRD post-transplant can be carried out, and actually by identifying at different thresholds. So in the study on the left, you can see the level of MRD detected at 0.1, 0.3, or 0.5 will stratify patients as to their risk of their relapse-free survival. And similarly, the incidence of relapse significantly goes up is significantly observed in these patients with high MRD. And in terms of MRD is the most important predictive factor in that particular study for relapse. There are other factors which are also important, such as P53. And so there will be interaction between some of these, but clearly we are perhaps reaching in the coming years an ability to use detailed and sensitive MRD tests to help predict and maybe enable intervention. In terms of maintenance post-transplant for high-risk MDS, there are a few studies that have been published, including some randomized phase 3 studies and a phase 2, looking at azacitidine maintenance and APR 246, but so far none of these clinical trials have shown benefit. And there are some other studies that have looked at drugs such as enasidenib, venetoclax and azacitidine, and ivosidenib in phase 1, but we need to await randomized studies. And the oral azacitidine maintenance option has been evaluated in a clinical trial called Amadeus, which is a phase 3 randomized controlled trial looking at azacitidine versus placebo in high-risk MDS patients going to transplant, and will read out next year. What about the role of DLI? I will touch briefly on this. So DLI plus or minus some sort of chemotherapy has been used for either prevention of relapse using chimerism as a surrogate marker, or for treatment of relapse. And certainly our own study, I show the data from our single center published back in 2013 at the bottom. On the left, this data shows the effect of using preemptive DLI in patients with MDS or AML, 62 patients, using CD3 chimerism to guide administration of DLI, resulting in excellent overall survival of 80% and a 65% 5-year event-free survival. And based on these promising findings, we have carried out the PRO-DLI clinical trial led by Dr. Victoria Potter at this institution, and this randomized patients with MDS and AML to either early weaning of immune therapy and prophylactic donor lymphocyte infusion, regardless of chimerism results, versus a preemptive DLI strategy based on mixed myeloid chimerism. And the data from that should also be reading out most likely next year. So to conclude, I think in terms of how we can improve outcomes for these patients, we need to better understand the need for cytoreduction pre-transplant for high-risk MDS patients, and we need to understand what we're aiming for when we do this, for a marrow CR, for MRD negativity, for more than that. And then standardize MRD monitoring and incorporate this as potentially as a clinical trial endpoint. We need to optimize pre-transplant treatments and look at novel agents, and also improve patient selection according to disease risk, which at present is controversial. For example, considering the utility of transplant for P53 or very adverse monosomal karyotype disease. For conditioning, we should await the results of prospective trials such as COSY and consider novel conditioning regimens, which include new agents such as venetoclax. And there's still a question mark over the role of sequential conditioning, but perhaps identifying the right situation to deliver that in. And finally, prevention of relapse. We need to better define disease monitoring pre and post-transplant. So rather than surrogates such as chimerism, but actually have personalized specific disease monitoring that can give enough warning of relapse for time to intervene. We need to be able to risk stratify pre-transplant better and then personalize the post-transplant plan accordingly, and use strategies such as early withdrawal of immune suppression where possible, and the possibility of preemptive or prophylactic DLI to prevent relapse, perhaps with or without maintenance. And with that, I thank you for your attention.
Thank you, Dr. Paramela. And because of time, we'll go to the next talk. We'll leave the discussion at the end of the session.
Thank you. And it's my pleasure to introduce the next speaker, Dr. Michael Hodacek from Germany. He's a chair in the cellular immunotherapy of University Hospital in Wolfsburg in Germany. And he's director of Fraunhofer Institute for Cell Therapy and Immunotherapy and Cellular Immunotherapy branch site in Wolfsburg, Germany. Dr. Hodacek has an well-achieved career with CAR T cell, and he had a patent of more than 12 patents related to the CAR T, and he's a professor of immunology. Without further delay, Dr. Hadacek, the floor is yours.
Well, thank you very much for the very kind introduction. I do hope that you can hear me well and that you can see the presentation. I'm very sorry that I cannot be on site with you, but it's an absolute pleasure to join you at least virtually. I do thank the SSBMT and the EBMT presidents for considering me, and the two session chairs for the very kind introduction. So as the last talk in the session, and I will focus on future development of CAR T cells and an extract from work that we're doing at our institution and what resonated at the EBMT and ASTCT conferences earlier this year. So knowing that CAR T cells are now accomplished and are available to treat B-cell malignancies and multiple myeloma when targeting CD19 and BCMA, I think the big territory to still chart, at least in hematology, is acute myeloid leukemia. So I will in the first part show you cell products and target antigens that we are currently developing in order to achieve therapeutic efficacy also in AML. I will cover the topic of malignant transformation that is akin to the manufacturing scheme that we use to make CAR T cells, and we'll share with you some data that we have from our virus-free transposon-based technology to make CAR T cells. And finally, I'll show an example of teamwork that we've leveraged in Europe, and where we would be excited to have additional societies and countries join us from a European project called T2 Evolve, where we are looking at setting new standards and that will be beneficial for the field and that can be applied and used by stakeholders in this area. So looking at acute myeloid leukemia, this is an overview from actually a market search report to look at what novel substances are in the pipeline. And you see the majority of this pie chart is small molecules that cater for specific genomic aberrations that we find in AML. But you also see in the top that with gene-modified cell therapy, there's quite some movement. And you're aware that CD123 and CD33 CAR T and CAR NK products are in clinical trials, even though they've thus far failed to deliver the breakthrough that we've been waiting for. And we're analyzing and trying to understand whether this has to do with targets, with the entity that we're treating, and or if there are additional factors that we still need to understand better. As a SWOT analysis for CAR T cells in AML, our preliminary assessment would be that we know from the use of bone marrow transplantation that there is a potential for cure. We know also from the mode of action of CAR T cell therapies that there is the opportunity to deliver a single shot therapy that can replace the traditional induction and consolidation therapy that is established in this disease. The weakness is, and the open question is, whether we will ever find a CD19 analog and whether we can, with one target, address all of the AML subtypes that we know today. And the threat is compromised T cell or immune cell fitness after prior chemotherapy and hematologic toxicity that will result and is anticipated to result from most of the targets that we have in our pipeline. So here's a look at the pipeline, and the targets have been proposed by many groups in the field over the past years. It almost seems that there may be too many options in order to focus on one and really work through it with confidence. All of these targets are prevalently expressed on AML blasts. The majority of them also has been shown to express on the leukemic stem cells that we believe have to be eliminated in order to deliver a curative approach. You also see that all of these targets have some expression in normal hematopoietic cells. So I think titrating now the expected hematologic toxicity and therefore finding the therapeutic window and the appropriate patient population, I think is an important part of this journey. We have in our program focused on FLT3 as a CAR target for quite some time and are now ready to launch a clinical trial with this. FLT3 is, of course, known in the AML field because, as you know, it frequently harbors mutations like the tandem duplications that act as drivers of this leukemia, and for which now small molecule inhibitors have been developed, like midostaurin, gilteritinib, quizartinib, are clinically available. FLT3 is also a surface antigen, so it is akin or an amenable to targeting with antibodies, bispecific antibodies, and CAR T cells. It's actually quite consistently and prevalently expressed on AML cells, even higher and more uniformly than CD123. And so we've reported on the preclinical assessment of FLT3 CAR T cells that we find are very effective in delivering anti-leukemia activity. Learning, though, from the experience of targeting CD19 in acute B-cell leukemia, we also considered that antigen downmodulation or loss under the therapeutic pressure was probably a threat to this treatment, and therefore wondered how can we prevent AML blasts from losing FLT3 expression. And we focused on the subset of AML with FLT3 mutated that depend on FLT3 signaling as a survival and pro-leukemogenic signal, and treated them with FLT3 inhibitors. At the time, we used crenolanib, which is also on the way to clinical approval, but not there yet. And found that after treatment with creno, the FLT3 antigen density on the AML blast was substantially increased, and that would result in enhanced recognition and enhanced anti-leukemia activity of our FLT3 CAR T cells, as what one would expect a correlation between antigen density and ensuing CAR T cell reactivity. We also put this paradigm to the test in vivo, and you see this in the middle graph, where we treated mice with FLT3 CAR T cells and creno, and therewith achieved a complete response rate, actually the deepest responses, supporting the use of this combination therapy. Now, considering that this is a class effect, we also tested other FLT3 inhibitors and actually found the same phenomenon to be true also with the other substances. And quizartinib and gilteritinib actually conveyed the strongest effect. And we see here with super resolution microscopy where you can zoom in and also demonstrate single molecule expression that there is really higher antigen density on the AML cells. In part, these molecules are clustered, but they're certainly amenable to recognition by our CAR T cells. So we now have procured funding for a clinical trial to test this paradigm, where we first treat patients with an FLT3 inhibitor and then go in with our CAR T cells. And we're using in this phase 1 trial a Bayesian dose escalation regime to determine the maximum tolerated dose and recommended phase 2 dose. And this trial is anticipated to start next year. Sabrina Kraus from our department in Würzburg will be the PI for this study. Now, an anticipated toxicity of targeting FLT3 is hematologic toxicity and potentially recognition of normal hematopoietic stem and progenitor cells. The risk we are running where we are integrating this into the treatment paradigm for AML, and likely this would be after induction and consolidation where patients have not reached MRD negativity, potentially also for patients that do relapse after bone marrow transplantation, even though that may mean that we have to confirm a second bone marrow transplantation. And therefore, there has been also an interest to identify CAR target antigens that are not expressed on normal hematopoietic stem and progenitor cells, such as we would be able to treat patients that have a relapse after bone marrow transplantation. And we searched for and found a target antigen that fulfills these criteria, Siglec-6. The binding domain for Siglec-6 was actually derived from a patient, status post bone marrow transplantation. The patient had a chronic lymphocytic leukemia, and as part of the graft versus leukemia effect, and as part of the antibody response, our collaborator Christoph Rader fished out this antibody called JML1 that later demonstrated recognized Siglec-6. The Siglec family, sialic acid binding immunoglobulin-like lectins are known as CAR targets. Siglec-2 is the alias for CD22. Siglec-3 is the alias for CD33. So these are targets that we have used to target hematologic malignancies with CAR T cells. So it's another member from this group, this time in AML. And we've shown that Siglec-6 CAR T cells are quite effective preclinically. So they fulfill all the benchmark criteria in terms of lytic activity, cytokine production, and proliferation in T cells, and also in the mouse model, the xenograft mouse model that we've set forward in order to go into a clinical trial. I will point out, and it's shown in the lower left, that Siglec-6 is also retained on the leukemic stem cell compartment, and it's in many cases even higher compared to the bulk AML blasts. The important point, though, is that the cyclic 6 is not expressed on normal hematopoietic stem and progenitor cells, and we've shown this by flow cytometry, shown on the top left. We've also done the super resolution microscopy that really shows no expression by qPCR, and we performed colony formation assays in vitro, where we find that treatment of normal hematopoietic stem cells with the cyclic 6 CAR T cells does not compromise colony formation of all the major lineages, and is similar to untransduced T cells and different from CD123 CAR T cells that we know will recognize normal stem cells. So with this, we have a target in hand that has a unique property and could potentially be used in patients that have already undergone a bone marrow transplant. CD70 has been reported to have potentially similar properties, even though we've not been able to recapitulate this fully. So this is why we are now confident to go forward also with clinical development of CAR T cells against this target antigen. The anticipated hematologic toxicity may be related to the limited expression on some memory B cells and mast cells. Normal adult tissues, though, the only tissue where we find cyclic 6 expression is placenta, so this does not pose a concern. In terms of manufacturing, we've been working very hard because we think this is an absolute bottleneck for increasing patient access. It's important to bring down cost, and most of the cost is related to procuring relatively expensive viral gene transfer vectors and handling them in biosafety level 2 clean rooms. And therefore, we've focused on using transposition, and this is a virus-free manufacturing scheme. This is summarized on this slide where we're showing you on the left that transposition requires two components, a transposase, and this is shown in orange, that liberates a transposon, and this is double-stranded DNA from a donor plasmid, for stable integration of the gene of interest into the T cell genome. And we've found very efficient embodiment with transposase encoded mRNA and transposon encoded minicircle DNA that allows us to accomplish routinely greater than 60% stable gene transfer rate in T cells. This is, of course, very scalable. From a batch of mRNA, we can make many thousands of CAR T products. So it has a favorable biosafety level profile, so we can handle this in conventional clean rooms. And it's something that we've also put into practice in some of our clinical trials. So here are some action shots from the GMP room. In this case, this is at the Fraunhofer Institute for Cell Therapy and Immunology in Leipzig. And we're using this manufacturing scheme also to make our AML CAR T products. I will say that because mRNA and minicircle DNA can also be packaged into nanoparticles, for example, it's also a gateway technology to eventually do in vivo gene transfer, which I think will require some additional preclinical work and refinement, but I think in the next generation of CAR T products, we will already see implementations of in vivo gene transfer where we don't need ex vivo handling of our CAR T cells. The use of virus-free gene transfer is also important, considering the recent reports that flagged or the risk for malignant transformation that in the FDA report was related to the use of viral gene transfer vectors and the potential insertion into oncogenes or proto-oncogenes. Even though the number of cases that has been reported is very low, is very limited, and also the number of cases where de facto malignant transformation of CAR T cells has been observed is very little. I will also say that also with transposon technology, however, with the piggyback transposon, malignant transformation has been reported, and this is why we and our collaborators have been trying to get at the ground and the mechanism of action that is in place here. So two principal mechanisms that can lead to malignant transformation either are related to insertion into a specific gene locus that either releases the brakes on T cells and thereby increases their activation. And this must have been the case, apparently, in the case of the piggyback transposon malignant transformations, where in both cases there was insertion of the transposon into the Bach2 locus, a known T cell suppressor. And a couple of years ago, Zoltan Ivic, our long-term collaborator, had performed genomic insertion profiling and actually had shown that the piggyback transposon, very much like gamma retroviral vectors, seems to have an insertion preference into the Bach2 gene locus. The good news is this does not seem to be the case for lentiviral vectors, and for sure not for the sleeping beauty transposer. So this has a clear path here. The other major mechanism is so-called read-through transcription, where there are unintended transcripts resulting from the transgene, and this is mainly related to the promoter that is being used in the expression cassette. And we have developed some refined expression cassettes and promoters that further mitigate that risk. So with this, I'll turn to the last part of the talk and talk about some teamwork that we've been doing in creating an innovation ecosystem in order to accelerate the development of CAR and TCR engineered T-cell therapies. In the European Innovative Medicines Initiative, T2Evolve is a multi-stakeholder public-private partnership project that has taken on this challenge. I will say that EBMT is a full consortium partner, and T2Evolve works hand in hand with the GoCard project and GoCard Coalition. And where T2Evolve is a little more practical in a sense that we also have the ability to execute wet lab experiments, for example. But overall, work very synergistically with GoCard. The motivation to create this ecosystem is the recognition that there's so much innovation happening, and that, however, only a small number of these innovations ever makes it to the clinic such that patients benefit. So what a public-private partnership consortium can do is to help create standards that stakeholders in the field can use in order to accelerate benchmarking, preclinical development, and clinical translation. So that is the ambition of this consortium. There's many partners, there's major pharma, there's biotech, there's regulators, patient initiatives, also the professional societies. Both EHA and EBMT are full consortium members. And there's many academic partners that bring forward specific expertises. And of course, all of them are experienced immunotherapy centers. There's also a very broad stakeholder communities. So everyone is invited to join the stakeholder community, engage in the discussion, but also leverage and use the output that is coming from this consortium. And I'll show you two examples and two recent activities from the many aspects in the work program that the consortium has recently delivered. The first is related to patient and healthcare provider involvement and education. And T2Evolve has conducted a large survey amongst patients that have received CAR T therapy in order to understand what was the level of information, what was the patient experience, and in retrospect, what would patients desire to know better and to know more before they go into the CAR T-cell journey in order to help us improve the patient experience, but also the ability of healthcare providers at all professional levels, physicians, nurses, but also family healthcare providers to support our patients. The survey has now been, at least the first iteration has now been completed, has been conducted in several European languages. And more than almost 400 patients have completed the survey. It will be reported in full detail very shortly, and we're certainly also willing to share the survey with other societies so that they can conduct the survey with their patients. And in brief, what was really remarkable is to understand at what stage in the CAR T-cell journey did patients feel that they had required more information. And this was the case, for example, about the experiencing the acute toxicities, but also the short and the long-term follow-up. A question that came up in the survey is that patients sometimes just wanted to know, when will we be able to visit family and friends again? Will we be able to ride a bike again? These were practical everyday life questions, in addition to also medical questions like, is there a need to do vaccinations? What's the risk for infections, etc. So also quite medically related questions that came up. And there is quite an impact on the patient's everyday life. So it's another incentive for us as physicians to support our patients, to explain the CAR T-cell therapy with also materials that are catered for the specific patient population, young or old, that may have different preferences, to have either some reading material or an online tool or a video in order to get more information about this treatment. This is why we've also delivered and produced so-called explainer videos that, in addition to the material that is already online, can improve the patient experience, and that everyone also in the auditorium today is welcome to use and download. I will touch briefly on an effort that we also made to understand aspects of CAR T-cell manufacturing, standards in obtaining the leukapheresis material, for example. So we conducted again a survey amongst European centers that deliver CAR T therapy and that perform leukapheresis to understand, for example, what parameters are being measured when the leukapheresis is being obtained, but also on the product that is then being released from those trials that are investigator-initiated trials, where there is manufacturing of CAR T products at the hospital site. You see the results of the survey here. So you see that for several key parameters in the top part, there's consensus and many centers are using them, and there's additional parameters that only some of the studies are using and that are catered specifically for the CAR product or to institutional experiences or policies. Also, these results are now available and they can help novel centers and sites that want to implement CAR T therapy in the future in designing the program and in designing the criteria and correlative analysis that we're doing to production, but also then to the therapeutic use of CAR T cells. With this, I'm at the end of this short presentation. I do invite you to join us in our effort in T2 Evolve, but also in GoCARD, and Anna Soreda can probably provide more information on this. I hope that the short detour to acute myeloid leukemia was informative to show what are the considerations when we develop CAR T products to treat this disease and what are potential prospects when we are now entering into clinical trials. The aspect of virus-free transposon-based manufacturing, both from a practical point of view in terms of cost and scalability, but also from the genomic safety aspect in order to mitigate the risk for malignant transformation and other genomic toxicity, I think is important. With this, I'm at the end of this presentation, and I do look forward to any questions that you may have. Thank you very much.
Thank you, Dr. Michael. And I think might have a few minutes for question for Dr. Michael and Dr. Primala. Any questions from the audience? If not, I can start with a question to Dr. Hodacek about the CAR T. Are you using this CAR T platform for the AML? Have you used it for the B-cell lymphoma before? Was it used in any B-cell malignancies before?
The acoustics is not so strong. So I've understood that the question is whether we've used CAR T cells for B-cell lymphoma. Does this specifically relate to the transposon-based CAR T cells?
Yes.
Yeah, that's an excellent question because the transposon system also is still technically new. We've not performed a formal clinical trial ourselves. There have been other investigators in the field that use transposon technology and that have seen efficacy. These are investigators in the US and also in Australia. So we've performed extensive preclinical testing and benchmarking, and we see that in terms of efficacy, the transposon-based CARs are at least equivalent, in many aspects even better because of their specific genomic insertion profile. There is less genotoxicity to the T cells. So they have superior attributes in terms of proliferation and persistence compared to the viral counterparts. But we've not performed a formal clinical trial because in Germany and Europe, I think the current market is covered with the available products. Even though I will say that I think now that we're going towards even more scalable manufacturing, also in vivo manufacturing, and this is where also the transposon technology is a gateway for us. There is certainly the interest to reconsider the CD19 because you don't want to have too many variables in your investigation. Did that answer your question?
Yes, yes. And what is the turnaround time for the manufacturing?
For the previous trial, this is what the Karamba trial with STEM7 and multiple myeloma. The turnaround time was 12 days, and that was a fresh vein in, so fresh in, fresh out product, and the vein to vein time was 12 days. We're now working towards 7 days. And at least in the lab, we can also do same day manufacturing where we make a cell product in 24 hours. But these are some concepts that are still preclinical that we've not implemented clinically yet because it poses some challenges with the release testing, because if you're so fast, you may not even see CAR expression yet. And then the question is, well, how do you release the cell product and how do you demonstrate consistency? So they were working currently on this. In the clinic, we're down to 1 week now.
Dr. Parvella, I need your opinion regarding the age limit and about the intermediate 2 days going to transplant. should we go for this transplant or we
have to
have to
see
see
the
the
progression,
progression?
especially in
Especially in
Saudi
Saudi
Arabia, we
Arabia,
have
we have
younger
younger
population,
population,
the
the
incidence of
incidence of
MDS are
MDS are
early
early
60s or late 50s.
I'm sorry, I found it hard to hear the question exactly. Do you mind repeating?
So
So
I'm talking about the age limit
age
of the
Oh, the age
transplant,
limit.
and the second point is the intermediate two risk of IBSSR.
So, in terms of the age limit, there have certainly been studies which have looked at the utility of transplant in older patients using reduced intensity conditioning, and certainly it is a feasible approach, given that the majority of patients are median age sort of 70. It is appropriate to look at ways to transplant these patients. In terms of intermediate 2, is your question, what was your specific question about intermediate 2, sorry?
Do you offer them transplant if you think that this group of patients will benefit from transplant?
Yeah, so as I showed in my talk, I guess, I was talking about high-risk MDS. We're talking particularly about patients. If by high-risk MDS, we're essentially talking about the intermediate 2 or higher patients by the old IPSS, or we're using scores around 3.5 for IPSSR. And these patients, yes, certainly they are the highest risk of progression to AML, of shortening of their lifespan. Therefore, the only potentially curative option for them is allogeneic transplant. So understanding how we can get them to transplant, how we can keep them in remission, remains kind of the area that we need to address.
Yes. There's a question from the audience. So the question is for Dr. Wajik. So this is actually a very interesting way you have shown how the methodology, immunology are actually making those cars able to survive less chance for exhaustion. Are we actually getting any close to having multi-target cars? Because where we are desperate are the adverse cytogenetics, AML, they have multiple clones, most of them are driving clones. Are we getting close to having multi-target cars or not?
Yeah, it's an interesting, good question, and I do agree that the heterogeneity in AML is a challenge, right? And with FLT3 and cyclic 6, though, we see quite consistent expression and very prevalent expression on several AML subtypes. Even now that we look according to the WHO classification, which is guided by specific genomic aberrations and mutations, we see that the FLT3 and the cyclic 6 are quite consistently expressed across several genomic subtypes. Of course, the opportunity with the FLT3 is that in those cases where the FLT3 is mutated, we may have the ability through co-treatment with the FLT3 inhibitor to prevent antigen downmodulation. But the thing is that we don't know for sure that this would even occur, because we so far have not treated patients with this. It's just kind of an anticipation from what we've known or what we've seen with targeting CD19 and BCMA and other malignancies. So I do agree that, of course, multi-targeting, multi-antigen targeting is of interest in AML, but we'll also make sure that we're not kind of jumping too far at each time, because with using 2 targets at a time, also the potential for toxicity will be increased. So I think it would be would be better to go kind of stepwise, determine what is the activity, maybe then also cater or use single antigen targeting CAR T products in specific AML subtypes if we find that they're useful, and then go to the multi-antigen targeting where we need it. Does that answer your question?
Yes. And my second question is for Dr. Krishnamurthy. We actually have all acknowledged how heterogeneous MDS is, and you've shown excellent, beautiful summary of the slides, how even sometimes the older belief that cellular burden is the true measure before proceeding for allo. So, and you mentioned something I'm always a big believer of, which is conventional chemo causing selectivity of quiescent clone. Would you not say that this could also be the case with myeloablative and trying to aim for more myeloablation when you transplant those higher risk MDS? Wouldn't also myeloablation cause that negative selection of quiescent clones?
Yeah, I think it's a really good question, and I don't think we know the answer as such. I think it's so complex in terms of the underlying disease itself, and as you mentioned, the interaction with the degree of the conditioning. I mean, even with azacitidine, it's possible to see selection of different clones, so it's not. I don't think we know enough about whether or which type of drugs causes particular selection of clones. I think it'll be we've seen in AML as a sort of extrapolation that it's possible to see, for example, FLT3 selected clones coming out after venetoclax, and you would anticipate that there would be similar kind of selection of clones with these different drugs. So I think on the one hand, you think a targeted agent could be good, but then it could then increase the risk of drawing out a particular clone that can escape, and therefore your suggestion may be that these more broader types of chemotherapy may have lower chance of selectively targeting a particular clone, I guess. But I don't think we understand enough about it. We don't understand enough about how to measure these clones and then how to interpret what happens to them either pre or post transplant or following chemotherapy, even to understand what to do about it at this stage. But I think it's a good point.
Thank you.
Thank you very much, and thank you for the audience. And I'd like to thank Dr. Primal and Dr. Hadachek for excellent talk. And I think with that, we can conclude our first day today and congratulate the SSBMT for a successful meeting. And we'll see you tomorrow at 9 a.m. for the second day of the SSB our meeting. Thank you.
Thank you for having me. Thank you.